colleagues, ladies and gentlemen, welcome back to our virtual meeting on interventional cardiology, who hold by the Vietnam Society of the Interventional Cardiology, Thống Nhất Hospital, and particularly cooperated by from faculty from United States of America. I am Dr. Hồ Thư Dũng, President of the Vietnam Society of Interventional Cardiology, Thống Nhất Hospital, and my co-chair is very familiar with us, Dr. Thạch Nguyễn. He is big brother, a close senior for all interventionists of Vietnam. And the session today is the session 6 with the topic, optimal PCI of complex lesion. We have a 5 session previous talk on the individual topic of difficult lesion, such as the left-man PCI, bifurcation PCI, very calcified PCI, small, diffuse, long, tortuous lesion, and repeat revascularization or extensive stenosis. So today, I think our topic is look like a summarization of the many previous sessions. Nowadays, interventional cardiology often have a lot of the difficult case in our cath lab because the elderly population increase very quickly and account for majority case coming to our cath lab. And Vietnam interventional cardiology is the same situation, not different. We hold this session with the hope for young interventionists to know how to recognize and how to assess the complex lesion, how to make a plan of the PCI for complex lesion, how to do complex PCI with many techniques, variety techniques, and how to utilization assistant instrument or device to support intervention. We can learn many excellent lectures from experts. We can hear opinion, discussion, and advice from experts of the both sides in Vietnam and America. And by now, I'd like to introduce the Vietnamese faculty team. The first is me, Professor Hồ Thư Dũng. The second, Professor Nguyễn Ngọc Quang, Vice Director of the Vietnam Heart Institute, Hanoi, capital Vietnam, or General Secretary of Vietnam Heart Association and Ambassador of SCAI. The third, Professor Nguyễn Văn Tông, Director of Interventional Cardiology Department, Thống Nhất Hospital, Ho Chi Minh City, Vietnam. And the fourth, Dr. Ngô Minh Hùng, Vice Director of Interventional Cardiology, Chợ Rẫy Hospital, Ho Chi Minh City, Vietnam. And the last but not least, Dr. Đinh Đức Huy, Director of Cardiology, Tâm Đức Heart Hospital, Ho Chi Minh City, Vietnam. And by now is the time for you, Dr. Thạch Nguyễn, introduction with your team.
Thank you very much, and good morning, Vietnam. It's nice to see all of you here. And we have with us today Dr. Dwayne Pinto, our close friend from Boston, and Dr. Gautam Kumar, a very well-known interventional cardiologist from Emory. Today, we will tackle some major and difficult problems we see in both sides of the Pacific, in Asia or in the US, and how we approach a problem, how we solve it, how we bring good results to the patients. So I would like to introduce Dwayne, Dr. Dwayne Pinto. He is a Chief Interventional Cardiology at Beth Israel Deaconess Hospital in Boston. And he will talk today about complex PCI, especially in-stent restenosis, because right now in Vietnam, we have a lot of in-stent restenosis. Dwayne, thank you.
Thank you, Dr. Tak. It's good to see so many of my friends over the many years, and it's my pleasure to talk with you today. I'm really impressed with the practice of interventional cardiology in Vietnam. And unfortunately, though, we suffer the same complications of our stenting procedures throughout the world. And in the current era of drug-eluting stents, in-stent restenosis is something that we really have to be familiar with and how to treat effectively. Now, the causes of in-stent restenosis range from drug resistance, infrequent things like hypersensitivity, stent fracture, and to more common things like neointimal hyperplasia, geographic miss, meaning we miss the lesion or miss the area that we injured with angioplasty, and something that is a problem that we can do something about, a problem of the index procedure, is stent under expansion. But when I trained, there was a lot of restenosis. Around 30% of cases had restenosis in the bare metal stent era. The time course was maximal by 6 to 8 months. And the histopathology was of neointimal proliferation with a lot of smooth muscle. There was complete endothelialization of the stents by 3 to 6 months. There was infrequent neoatherosclerosis. This is very different than what we are dealing with now, where restenosis can present very late, out to 5 years. The neoatherosclerosis is very common. And so I think when we need to think about these things, I think first of all, we need to think about what we do as interventional cardiologists to contribute to this problem. And I want to draw your attention to two concepts. One is malapposition, where if you look on the top panel, that because of the nature of the blockage, for example, a calcific blockage or a very recalcitrant stenosis, we can place the stent and it may not be circular, but it has a very good minimal stent area. And in that case, the artery is differentially expanded, but we have a good lumen. This should be contrasted with stent under expansion, where you see the proximal reference is, in this instance, 6 millimeters squared, but the stent is not opened effectively. And in the center portion of the lesion, the stent is not increased, and that's defined as a minimum lumen area less than 70% compared to the reference. This is when we deal with lesions without adequate preparation, and we put in a stent and we leave a very small lumen. This may not be apparent angiographically and is sometimes only apparent on imaging. But stent under expansion contributes to early stent failure. You can see that under expansion overrepresents the smaller the minimal stent area, the more frequent there is for neointimal proliferation at the lesion area, at the lesion site. And in a large meta-analysis looking at a large number of patients, IVUS-guided implantation, presumably with larger lumen areas, results in improved clinical outcomes, including death. And there's a mean difference of about 0.33 millimeters when you look at IVUS-guided PCI. So it's not surprising that we see improved clinical outcomes in randomized trials of IVUS at this point, but I show you some pictures of OCT where one of our main problems as interventional cardiologists is dealing with calcium. And you can see that very thick calcium, first of all, is more easily seen with OCT, whereas IVUS shadows calcium. We can really see an outline of the thickness of the calcium, the circumference of the calcium, and the length of the calcium. And it's relatively easy to remember the criteria for severe calcification. So more than 50% of the circumference, a thickness of at least 0.5 millimeter or a length of greater than 5 millimeters is calcium that's going to presumably lead to stent under expansion. So imaging is critical for guiding our strategy for in-stent restenosis. If there's an unstented gap or there is an area of geographic miss, then balloon angioplasty and stenting are options. If it's neointimal hyperplasia, then we need to deal with that, and angioplasty, laser atherectomy, or DES, stent fracture, repeat stenting. An undersized stent needs to be sized appropriately, and we need to expand that stent. We need balloon at high pressure or a scoring balloon, or perhaps a larger DES. Again, under expansion, we shouldn't be putting in another stent for under expansion. We should be inflating the lesion with balloon angioplasty. We should be dealing with the plaque so that it can now expand. And if there's 2 layers of stent, then it's probably not the right thing to put in another 3rd layer of stent. So laser, radiation therapy, if available. In the United States, we're not approved yet for drug-coated balloons, but obviously these are choices outside of the United States. So balloon angioplasty, obviously non-compliant balloons, but we're familiar with the scoring balloons like the cutting balloon, the chocolate balloon, as well as the angiosculpt balloon. Balloon angioplasty for patients with multiple DES has been looked at, and we see that there are some advantages, but not an overall huge benefit for drug-coated balloon versus a 2nd generation DES. But I believe that this will be completely predicated based on the acute lumen gain from the PCI. But what happens if we're to put in a 2nd DES? So if we look at the rates out to several years of single layer DES, and the event-free survival is somewhere around 87%. But if we look at target failure rates for the 2nd stent, they're somewhere around 10 to 12% at 1 year, and 1/3 of patients at 3 to 5 years will suffer target lesion failure. So we're obviously not doing as well with 2nd layers of stent. And a 3rd layer of stent, 25% of patients will return within 6 months. And this is what these stents look like when they're put on OCT, when multiple layers of stent are put in place. So you see neointimal proliferation and progressive occlusion of the lumen without adequate expansion. So in the United States, we use laser atherectomy that vaporizes the neointimal proliferation. It also leads to an acousto-mechanical effect, particularly with contrast, that can allow us to expand the stents. In some cases, we will need to do rotational atherectomy to ablate the stent and to further break up the plaque. So lumen gain in a small series of patients is about the same, but the overall cross-sectional area is increased substantially with laser when compared to angioplasty alone. The new kid on the block in the United States, even though it's been available outside of the United States for quite some time, is intracoronary lithotripsy. It's not approved for in-stent restenosis. It remains to be seen of whether this technology will be allowing us to open under-expanded stents. But here's an example of pre and post lithotripsy and post stenting in a case of Ziods, where shockwave was used to open a heavily calcified lesion and facilitate stenting. So here's an algorithm, perhaps to think about how to address a patient with DES restenosis. If the stent is mainly a problem based on imaging is neointimal hyperplasia or neoatherosclerosis, then laser atherectomy to ablate the disease, high pressure scoring balloon 1-to-1. And then if there's complete expansion confirmed by imaging, then if there's a single layer, then restented. If there's greater than if there's 2 or more layers, then perhaps a drug-eluting balloon. If the stent is undersized, then high pressure balloon, confirm that there is expansion. If there's not, then laser with saline and then contrast. And then if there's adequate expansion, then stenting if there's only 1 layer. However, if there's resistance, then rotational atherectomy is performed. Perhaps we would add in shockwave at this point, but this is just a way that I think about in-stent restenosis. So a couple of quick cases. There's a 77-year-old woman with coronary disease, chronic kidney disease, had a stent placed 2 weeks prior, and the balloon didn't expand at 24 atmospheres, but the operator decided to place a stent anyways. And the stent, I guess, on angiography looks okay, but when you really zoom in on it, you can see that the stent is really severely underexpanded. You see here, and you see this on OCT. So really, this is an underexpanded stent with a profound risk for restenosis and stent thrombosis. So this time, laser was performed, followed by 2.5 and 3 millimeter angiosculpt balloon with adequate expansion as confirmed on OCT, you can see here. Here's a laser atherectomy case with rotational atherectomy. It's a post-bypass patient where you can see this very severe circumflex restenosis lesion with 2 layers of stent that were non-expandable. It had recurrent chest pain and lateral ischemia. The small lasers and the larger laser would not cross. So ROTA was performed initially. Here's the OCT demonstrating 2 layers of underexpanded stent. And you can make out some thrombus as well as neointimal proliferation. And then after 125 and 15 rotabur, angiosculpt balloon was performed, angioplasty was performed with good expansion. And pre-rota and post-rota and pre-dilation, there was good expansion. And then in this case, only rotational atherectomy, followed by balloon angioplasty in one area distal to the an index lesion was stented because of dissection. This is the final result. And then finally, a gentleman with an acute inferior STEMI brought to the emergency department 20 minutes after symptom onset, total occlusion of the right coronary artery in a stented segment that was profoundly underexpanded, even though it looks pretty good angiographically. But I think we can make out that this is a very large artery. And OCT confirmed that there was a lot of thrombus and a very underexpanded stent in a very large artery. And so this was opened appropriately, dilated above 4.5 millimeters. And this is the final result. And you can see that the artery is much more well-sized to the distal vessel. This is the final angiography. So with that, I'll stop and summarize. First-time DES in-stent restenosis is common, with rates as high as 10% at 5 years. Treatment options for multi-layer ISR have high failure rates that exceed 40% at 3 years. Index optimal PCI should focus on preventing ISR. We need to maximize the stent minimum lumen area, minimize residual percent diameter stenosis. Intravascular imaging should be applied to moderate complexity lesions, including long lesions, and will reduce lesion failure rates by 50%. Intravascular imaging should guide all ISR and stent failure, and scoring balloons, laser atherectomy, rotational atherectomy can facilitate treatment by optimizing stent expansion prior to another DES implantation. And with that, I'll stop. And again, thank you very much. And it's very good to see many of my familiar friends again. Thank you.
Thank you very much for your presentation, Professor Duan Pinto. So can I ask you a question related to this issue or not, Professor Pinto?
Yes.
Yes, so usually nowadays we use a lot of DES, and of course we're facing with the bifurcation lesion. So I think that the bifurcation lesion is a high risk of ISR. So with the true bifurcation ISR, so how do you deal with that without the DB? Thank you very much. In the US,
Yeah,
we don't have DB, is it? Yeah.
Yeah, so bifurcation stent restenosis is an even trickier problem. Very often, particularly in the left main, we are underexpanded in the ostium of the circumflex. And I think that's the vulnerable area. Obviously, the ostium of any side branch is our vulnerable area. And I think it goes back to the index procedure. Are we performing optimal kissing balloon inflations, pot, etc.? But then even if we have a very good result at the end, and they get restenosis, I think it still applies many of the principles that I talked about. We have to understand the mechanism of the restenosis. Perhaps it's under expansion or neointimal proliferation in the branch, and we have to deal with it accordingly. And even in the parent branch. So I just think it means that it's going to be a more difficult and long procedure, but we have to deal with both arms of the bifurcation, and there may be multiple mechanisms of failure in that case. But very often, I think it can be traced back to imperfect technique at the time of the index bifurcation stenting.
Yes, thank you very much.
So Dr. Pinto, thank you very much for sharing the case of in-stent restenosis. So back to the case with the stent under expansion, when your colleague leave a stent that is truly under expanded in the LED lesion. So the case was successfully treated by laser in your site, but may I ask if laser is not available in Vietnam? So is there anything else that we can do? So the lithotripsy, the IVL technique, does it make any sense in that case?
I think, it remains to be seen whether an underexpanded stent like this without circumferential calcium will work with lithotripsy. There's some accumulating data that nodular calcium can be treated with lithotripsy, but I think we don't know the truth yet. I think at this point, if I were in Vietnam and not have everything like I have in the United States, I would be using OPN balloon at very high pressure, scoring balloons, and again, I'm very interested to hear what you would have to say. Maybe we try to get it expanded and use a drug-coated balloon, and we keep the people on aggressive dual antiplatelet therapy if it looks like it's still underexpanded. But I really think, again, this is a major technical error in interventional cardiology. You really can't put in a stent when your pre-dilation balloon doesn't expand. It really poses an incredible problem. So I think that's where our focus should be, is on the index PCIs, so that you don't have to deal with this problem. Obviously, I show a very exaggerated case where it's so obvious, but I do think most frequently we are undersizing stents, when we put them in. And I think that's a lesson we're slowly learning in the United States, very slowly, because we're very slow to adopt intracoronary imaging to guide our PCIs. And I think that's where perhaps our colleagues outside of the United States are more advanced than us, because they are seeing the stents when they first put them in, they're seeing the lesions, they're treating them appropriately and sizing it effectively. I will say my own practice has evolved in the last 2 or 3 years to involve more imaging, and I'm seeing the mistakes that I was making before.
Thank you.
May I have one question for Dr. Pinto?
Yes,
Look like
Professor.
a similar question of Dr. Denukhui, but a little bit different. The instant stenosis type maybe a type 4 total occlusion according to Wassman new classification. And I think in the total occlusion of instant stenosis, the plaque burden is very large. And in Vietnam, we try to wiring, we try to open cutting balloon, but I think plaque modification not enough, because plaque burden very large. If you cut the balloon and you give a new stent, the plaque burden still there, and it will induce the recoil. So we must do plaque depoking atherectomy. And in Vietnam, by now we have just only rotational atherectomy. But we have no many experience about us. Can you have some experience to give us such as which kind of the lesion of instant stenosis we can use? Because I think in some case with the stent is acute angle or tortuous or long diffuse, the rotable very easy to get stuck.
Yeah, I think you bring up two incredibly important points, is that when there's a lot of neointima and a lot of plaque or neoatherosclerosis, you have to debulk, because before putting a new stent in, otherwise you get this problem of like progressive closing of the artery because you can't expand properly. I would say that particularly in the circumflex and in some right coronary arteries, there is a lot of tortuosity, and the rotor burrs I'm more concerned actually in a native artery with a deep cut and a perforation. But in these stented arteries where there's a lot of plaque, I think patience and a small burr 1.5 will work even with tortuosity. And I like to use the Rota floppy wire rather than the Rota XS wire, because the Rota XS wire will pleat the tortuosity and then you'll have a deep cut. So I like to just follow it with small movements and be very patient. And then you have to be prepared to use multiple burrs and increase size. And so you have to be prepared with 7 or 8 French guide to use 1.75 burr, maybe even a 2.0 burr. And I obviously wouldn't get that big of a burr in a smaller artery that's tortuous. You have to know when to stop. But I think if you've debulked the artery well enough, you've shown that by imaging, then it's time to do aggressive cutting balloon and maybe drug-eluting balloon at that point in your practice. But I very rarely use the 1.25 burr, because the shape of the 1.25 burr is different than all of the others. It's more shaped like a watermelon seed, and it can slide in and gets more often stuck. So I'll just be very gentle and slow and patient with the 1.5 burr in the setting of tortuosity, and then creep up on it with a larger burr, and then particularly in the LAD, then I'll use a very large burr if necessary. But those retroflex, circumflex, or the shepherd's crook right, those are very challenging, like you said, and that I think takes some patience, and they can be very scary.
Okay, thank you. In Vietnam, because of economic reason, we often use only one burr for one patient. So can we use one burr in combination with the scoring balloon or cutting balloon? In my experience,
I get it, and I totally agree. I wish all of our systems allowed us to do what we needed to do, but that patient is going to end up being very expensive to the system because of restenosis. They're going to come back, with angina multiple times and multiple PCIs. So again, I sound like repeating myself, but it's why it's so important to try to get it right the first time, because it just makes it so expensive and complicated and dangerous, the second and third time.
Thank you, Pinto.
I'm interested to hear from you all, because you deal with this, in the real world without everything that I have available to me. And it's easy for me to show laser case and OCT and all these things. And, my, worry is, do I do laser with contrast or laser without contrast, and these things? How do you deal with it, when you do this, and with the options that you have, and what's your experience? How often do the patients come back? How frequently, do you use drug-eluting balloons? We don't have them for the coronaries. So what's your kind of practice?
Yeah, Dr. Robin.
Yes, say again. I couldn't hear that. Sorry.
Oh, yeah. So in my experience, when I use one burr, small burr, in combination with cutting balloon, or some case with only cutting balloon, I think the effect is not effective, because I think the burr can make blood depolking, but the cutting balloon cannot. So after we deploy one more stand, I think the lumen not in lab, and some patient after 1 year or 1.5 years, they come back again with instant restenosis and become type 5, many layer stand, onion skin. Yeah, very difficult for us in Vietnam. I hope in the near future we will have an intravascular lithotripsy. It seems look like very beneficial for this situation.
Yeah, but I think we will have the same situation where you need some sort of debulking, because I think all of those layers with the neointima, especially if the problem is not calcium, I don't know that the lithotripsy will be enough. Maybe if the problem was calcium and it's cracked down, now we can open the stent better. My hope, but it still also is very expensive for us in the United States. It's somewhere around $4,000, and it's not like you can reuse the catheters or anything. It's it has only a certain amount of life, only certain pulses, and then it's done.
Yes, I think that I agree with Professor Pinto that we use the IVL for the calcified lesion, and without the calcification, so I think we use another weapon in order to deal with the ISR. So I would like to ask Professor Wang, do you have any question on the topics I asked from Professor Pinto? And
I think I totally agree with Dr. Pinto mentioned about the first time when we do the PCI, we need to optimize everything first to avoid the potential future complication. Because sometimes after you put a standing, nothing you can do, even with a lot of device. And I want to ask Dr. Pinto about one thing. Is there any situation when you can stop the procedure without put the stent after you do a lot of dilatation?
For in-stent restenosis, Dr. Quang, or just a
No,
native lesion?
No, native lesion.
It's a good question. Back, at the very beginning, stents were invented to prevent abrupt closure. And then they also reduced restenosis by increasing minimum lumen area. So that's where the idea that bigger is better came from. But in CTOs or in a dissected vessel where I've starred to open the vessel, and maybe I don't want to stent the entirety of the vessel, I'll often leave the lesion alone to heal. And if some area of restenosis comes back, I'll treat that focal portion. Sometimes in small blood vessels like side branches and such, I'll just do balloon angioplasty alone, just like you. And then, sometimes if there's an area that I get an extremely good angioplasty result and the patient has a problem taking DAPT, they have an upcoming surgery, or they have a bleeding problem, I may do balloon angioplasty alone, knowing that, again, perhaps I can deal with restenosis later after their bleeding problem has been fixed up. So those are probably the three scenarios that I don't mind not putting in a stent, but I'd say 95% of my cases, I end up putting a stent.
Thank you very much, Dr. Pinto. And I think that sorry, Dr. Watson, I want to have another opinion from Professor That Nguyen that is there any difference between the concentrics and eccentrics ISR? If you deal with this that kind of ISR, so what is the difference between the concentrics and eccentric? Thank you very much. Professor,
have you asked me? I asked Dwayne, can you answer this question? Because in my part.
Dr. Tak, we're having a hard time hearing you.
Can Dwayne, you answer this question about eccentric and concentric in-stent restenosis? Because I don't have a lot of in-stent restenosis in my practice anymore.
Dr. Hung, was your question about the concentration of the drugs within the stents? I couldn't really hear.
Yes, so sometimes we see the concentric ISI. It means that it very concentrate from the and eccentric. It means that just some place that they had the ISI. So other segment we don't see anything. So with that, so any different from the management, for example, rotablation or the laser or something like that. Any different?
Yeah, I'd say most often on imaging, I'm seeing concentric ISR. It's infrequent that I see it not involve almost the entirety of the stent circumferentially. I will see focal areas of underexpansion that may be eccentric. And in that case, I'll just dilate with the balloon, etc. But I just apply the same strategy as I put as the algorithm for in-stent restenosis. But I don't really, the morphology of the restenosis beyond, is it neointima or not? I usually apply the same.
Yeah, thank you very much. So I think the time is a little bit over for this discussion. So I would like to thank you very much. I think that we come back to ask another question on your topic because very interesting. So I would like to introduce next speaker, Professor Hồ Thường Dũng, on the topic about the how could we do complex PCI. Professor Hồ Thường Dũng, please.
Oh, can you see my presentation?
Yes, I see clearly.
Oh, I messed it larger. So nice. So I cannot make it larger. Where I can make it my slide larger. Slideshow. Or okay. Yes, my presentation today is about complex lesion BCI, and I focus in a very calcified left-man intervention. Very calcified left-man intervention is often complex BCI. And I'll remind quickly about what's complex BCI according to the definition of a 2020 SCI. We have at least the three factors. The first factor related to anatomy. It means difficult anatomy, multivessel disease, calcified lesion, left-man bifurcation, instant restenosis, look like the presentation of Dr. Pinto. CTO, self-finite vein graft disease. And the second is the comorbidity of the patient. Look like heart failure, acute coronary syndrome. It will make where it will make the patient become very easy, unstable, and maybe hemodynamics, the compromise. And the last about we must have the support from the instrument device, such as the atherectomy, such as cover stand, such as IVI, so on. And the evil rarely go along. Complex BCI would be more complex when there are a combination of many phenotypes of complex characteristics. So my presentation, I like to talk about us. And my topic is a very calcified lesion. So we talk quickly about characteristics of left-man BCI. Why left-man BCI is complex BCI? Because the left-man trunk is very special anatomy of coronary artery disease. It supplies blood for whole left heart. And as we know, just only 40% of compromise, it can induce cardiogenic shock. It's the largest bifurcation with not small side branch circumference. It have a strong recoil elastic strong power, and it have a large vessel diameter. It's very mismatch between the left man and LED and circumflex. And in the left man disease, sometimes we have a CTO of the right coronary artery disease. So it becomes the last remaining vessel BCI. As you know, the last remaining vessel BCI is very dangerous. It's very easy to fall into the cardiogenic shock because we do the last remaining vessel supply blood for almost whole the heart. And we talk about characteristic of repeat revascularization. I don't talk about that because Dr. Duan Pinto have a talk very clearly. But I have one case for left-man BCI in combination with instant restenosis. And one more, the calcified lesion. In the very calcified lesion is very challenging. To get successful PCI in the patient with coronary calcified lesion, requires many advanced procedure training and skill. I think everyone know about the strategy technical problem when we do the calcified lesion. Even without significant lesion, may be difficult to deliver the equipment distally, and at high risk for stent stripping, very difficult to cross lesion with wire, and possible to wire but not crossable with device. I have some kind after. And we not possible to fully extend stent or stent regret. And we need necessary technique and instrument such as the rotor bladder. And because it's the many obstacles, so the patient after calcified lesion PCI often have a worse outcome. Post PCI myocardial infarction, restenosis, stenosis, lesion revascularization, dissection, rupture, perforation. And I have some guide for demonstration and for us to discuss or to us to receive some advice from expert. The first case is the left-main bifurcation disease in combination with repeat revascularization. In this case, instant restenosis type 3. Or the patient will do the BCI stenting at the 3 times. 2015, 2016, 2018 with the 5 stent and 3 DAS and 2 BVS. And the patient very severe COPD type D. And recently they develop frequency dyspnea, sometimes Japan. And this is the coronary angiogram. It's in the right side. We can see a severe, long diffuse lesion along the proximal, mid-segment, and the distal segment. And when I see about the history of PCI, look like in the RCA, the patient were deployed to BVS. And about the lab, we can see the first stenosis, the distal left main, and involve pole of ostium of LD and circumflex. And we can see the one stent from ostium to proximal segment of LAD have instant stenosis. You can see in here very clearly. A stent covered from ostium to proximal segment of LAD, and we have it in combination with the distal left main disease, involve pole of ostium of LD and circumflex. And plan to do BCI with strategy. The patient have an instant stenosis of the LAD and RCA, so I think we must use IVI to assess which type of instant stenosis to choose a suitable treatment. The second, distal left main disease involves pole of ostium of LD and circumflex in combination with instant stenosis of LD, and look like heavily calcified distal left main. So we must select, we must choose intentional two-stent technique, maybe stent of LAD also for treatment of instant stenosis of LD. With two-stent technique, I think a TK cross or TAB is suitable. I have a lot of iVert clip, but my clip look like wrong. So today, when I insert the clip of the iVert, it made my laptop stop. So I have only some one. for the LED from inside to outside. Then the reverse stand. This toe stand is good, but we can see type 1 and type 2 under expansion in combination with neo plug and neo calcify. The lesion from mid-stand to the ostium. Very severe stenosis of ostium of LED. A little bit stand protrude to the left man. This is from circumflex. The circumflex look like very good, except the ostium and the mid of circumflex, the mid. Calcify. Proximal. And now the ostium very severe. So I drew this toe bifurcation left man. And according to Wattsman classification of extended stenosis, this case belongs to type 3 mixed pattern combined mechanical and biological etiology. And how we can treat this is for the right. I am not focused the right because it's not enough the time. In the right, the stenosis, but with the PVS, so by now we don't see the strut of the stand go for the long time, and we must use a scoring balloon, cutting balloon to prepare plug modification and standing. And the last result, you can see between two stands have a look like stenosis segment, but when I use invert, the stenosis only 30%. So I don't like to the full metal jet kit and I leave it alone. About the lab, the first I use the cutting balloon, a scoring balloon to prepare for instant stenosis. And I prepare a stenting for the bifurcation of the distal abdomen. And when I see in the IVUS, the distal segment of stand is okay, no restenosis and no under expansion. So I choose the technique, the two stand with the one stand in the ostium and proximal segment of circumflex and one stand from left man to proximal segment of LD. Fixing, and we stand in the circumflex, and we prepare a standing left man to LD proximal segment. That is the last result. We do optical, we do the final kissing balloon. And we have a recall the IVUS not the IVUS catheter not go distal, but in the mid segment of the stand. But the result is very good, but the file not good, so I cannot show here. It large result, right? Choreography. Okay. So the first case I like to show the evil or rarely go along It means one case with instant restenosis in combination with Blackman distal bifurcation lesion with the two-stent technique. And the second case, I talk about Blackman bifurcation disease in combination with very calcified tortuous diffuse. We call the rosary bit. Oh, sorry, bit D, not T. This is the left coronary artery. We can see left main heavy calcified lesion. Distal left main involved to the pole ostium and proximal of LAD and circumflex. And long diffuse lesion along the LD. In the left, very calcified proximal and mid segment of RCA. And so a detail when I do PCI in the RCA, but in the RCA, after we do IVERT, I must use rotablator because the calcified burden very heavy. And after I use rotablator in combination with the cutting balloon, I deploy stent, it's okay. I focus in the lab, as you see in the lab, very severe and diffuse and tortuous of the LD. First, when I do wiring, very difficult because it's a tortuous. It gets stuck because plug calcified burden very large. Because as you see, you can see, as you see, the LDD very diffuse and the total lesion can we use the burr. I think if we don't use rotablator, we cannot expand the stent, but with the risk for the rupture or perforation, so I must choose the smallest rotaburr 1.27. And it goes smooth with the high speed, about 180 to 190 rounds per minute. After we do a rotablator successful, we do a pre-dilatation. And with the support of Gidezella extension of guided catheter, we can put the stent for the mid segment of the LD, and the second stent covered from Blackman to proximal segment. What's the dilatation? So the last result, I think it's okay. I don't touch the circumflex. It's very complicated. So before PCI, after PCI, before PCI, after PCI, I think the result is good. And the last case I like to present for you, and I like to ask your advice, your opinion. In this case, a very, I think, very specific. One case with the left main bifurcation disease in combination with the very calcified long diffuse disease. But I have a plan to do calcified plug depoking of the proximal segment of LAD, but something happened and I must deploy stent to the left main. So how I can do continuous? Here, coronary angiogram. We see very severe calcified lesion in the distal left main and the proximal segment of LAD. the circumflex not large. So I like to select one stent technique, but I must do a preparation very well of the distal segment and proximal segment of LED. In the coronary angiogram, when I look for the left man and osteo left man, look like not clearly, look like not severe stenosis. I think some plaque here in ostium of the left man, but I don't pay attention very much to the ostium of left man. But some view have the lesion of the ostium of the left man. And the patient or CTO of the right coronary artery, so it become less remaining vessel for we do the PCI. Of course, we have a balloon pump in advance. So this is my plan to do a PCI calcification with large burden along distal left man, ostium proximal mixed LED. So we try to choose rotor in combination with the cutting balloon or scoring balloon. Stenosis severe calcified distal left man involve pole of ostium of LED and circumflex. We choose, of course, two stent technique is very good, but it might take a lot of time to do that. And it's very dangerous because this is the last remaining vessel. So I choose one stent provisional side branch technique. Of course, because it's the last remaining vessel, I have a standby balloon pump. Here we can see the first, the wiring very difficult because of very severe calcified in the proximal segment. As you see, and the tip of the wire go to the most severe stenosis calcified. And you can see when I push the small balloon 0.8 and 10 millimeter, very small balloon I have, it gets stuck in the severe lesion. And you can see the tip of the guiding catheter, some in, some out, some in, some out. When I put it jump out, when I put back the balloon, it jump in. You see? And because the ostium of the left man have a lesion already, so the patient become terrible, hypotension, chest pain, dyspnea. So when I check again, something wrong in the left man, ostium left man, I must deploy stenting of the left man immediately, slow flow into all the left man in the patient with the left remaining vessel. Very quickly, stenting from ostium cover the left man. Okay. After I deploy the stent cover the left man, everything's okay, becomes stable. So by now, what can I do? Continue that. Unintentional stenting of the left man, very new fresh stent of the left man. How can we use rotor ablator? Or we just use the balloon, cutting balloon, but the smallest balloon, 0.8 by 10 millimeter, it's very difficult to get out, to go through. So how we can use cutting? So what we do now, and I like to hear some, have a short discussion. I like to hear some opinion from experts. Maybe Dr. Pinto.
So just to confirm this scenario is that we have underexpanded stent in the left main that needed to be placed because the patient got sick with a lesion. And The question is how do we expand it further now? Is that correct?
Yeah. How we
So-
continue to do for the lesion in the proximal segment of LDD, very severe stenosis
Yeah.
here, very calcified.
Yeah, so, I would continue with a probably 15 millimeter cutting balloon, trying to get that calcified lesion in the prox LAD open. I would, do some intravascular imaging to see whether it's working or not. I wouldn't worry about perfection in the left main as long as the area was good enough, based on the intravascular IVUS. I think you've already been through a lot. The patient has been through a lot. I think at this point, it's to try to get a stable and good result in the prox LAD, and then we can let the patient recover if we want to optimize further later. But as long as you have a good result in the left main, as far as area, I think you're good. I think you're happy.
Yeah, thank you. Because of the smallest 0.8 by 10 millimeter cannot go through, cannot pass the lesion. So I think cutting balloon is bigger, and by now we cannot use the IVI because I think the IVUS or catheter of the OCT cannot go through. So
I think I would just dilate there. If you're having delivery problems, I personally would use guide liner, guide extension to try to deliver if I thought it was a backup problem. But I think just balloon, and try to get it open,
Yeah. Thank you so much, Dr. Pinto. Maybe one opinion from other panelists from Vietnam. Dr. Ngô Minh Hùng.
Yes, a very complicated case, really. So actually we is out of our plan as we said before we do the procedure. So now we have to say the patient's life first, as you did that in order to stabilize the patient. So now you're asking about the what we call that, the proximal LAD very calcified lesion behind the stent. So in this situation, as Dr. Pinto already mentioned, that you use the smaller balloon or multiple ballooning. That's the safer option. But in this situation, if we cannot open the LAD to get a little bit better flow for the distal myocardium. So if we cannot do that, so we have to use the smaller burr in order to rotate the proximal LAD. Of course, we have to use the for example, ST01 or support catheter in order to pass through the stenting segment, and then we do the stenting. But this is very risky for the patient because this is the last remaining vessel. I don't know you did the case with that which kind of option. Thank you very much.
Okay, thank you. I do the same your suggestion. Because the first I like to try rotator so much at each and Y. But when I do each and Y, we cannot do each and Y with the microcatheter because the microcatheter cannot go through the very stenotic lesion in the curve. So I must go the microcatheter to the lesion, and after that we go directly rotor Y go to the distal. But the rotor Y cannot go to distal. It gets stuck. Is this the position of the rotor Y in the distal part of the mid segment? And we try to do a rotor plater with the smallest burr is the 1.75. But we try to I don't have to have the microcatheter for suitable for the burr. So I try to manually bring the burr over the stent, go to the proximal segment of the lab man. Very difficult. But you see, the bird always like to go out, not come in.
I see that you have a balloon, or a wire in the circumflex.
But yeah, I wire in circumflex format, but backup, not another reason.
I wonder how big is the guide?
The guy, the 7 French.
Yeah, I wonder if you could anchor a balloon in the circumflex and try to pull the guide in farther and maybe help deliver, because it looks like it's a guide support problem.
Yeah, good idea. And finally, I can bring the bird over the stand in the lab man and into the ostium of the LE. Okay, you see 1, 2, 3, 4 cannot pass. 1 more, 2, and in the third, successfully.
It's a 1-2-5 burr or
1, 2, 1, 2, 5. Yeah, 1 boy, 2, 5. Only 1 bird.
Yeah.
And after the bird go cross the region, the Y go distal easily because it gets stuck in the severe stenosis, and everything become easier. And after we burr, we yield IVUS. This from it gets stuck in the stenosis lesion after the burr. It come from inside to outside, so you can see the stent. And the second go from outside to inside. It gets stuck here. And the third IVUS is the last result of IVUS, but the file not good. So it's wrong. So I continue to do in the angiogram. You can see small balloon, pre-dilatation, cutting balloon, and we use extend guide wire or Kidajila to bring the distal stent to the mid, cover the severe stenosis. And the second stent cover from left man to cover the proximal segment of LDD. And the final result.
Nice. The circumflex looks good too.
Yeah, lucky. Okay, I think the last result is good. So takeaway message, a very calcified lesion left-man intervention, really complex PCI. Interventionist need a good plan before to do. We need the IVI, plug modification or plug defocking. We should have some request ability interpretation of the IVI, manipulation of device for plug modification, booking balloon rotator. We should be familiar with the two-strand technique, and we should have a mechanical circulatory support nearby. We must do with a good team and teamwork. Young cardiac interventionists gradually encounter unintentional, difficult or dilemma situation. We must learn how to solve them. We should have a good plan before to do complex PCI, and we should predict some difficulties, some obstacle to overcome. Sometimes procedure get out of our plan, even the best one. Look like my case. Keep your calm, ask senior advice. In most of cases, they often have some solution. In last resort, ask senior health or heart surgeon help. To do the complex PCI, we must learn to solve difficult or complication. Okay, thank you so much for your listening.
Thank you very much, Professor Hồ Tượng Dũng. for sharing us the three interesting cases, especially the third one, when patients presented with very heavy calcified lesions in left main LED, torsus also, and it can be considered as the one remaining vessel for the heart. So I believe that you are a very strong man, a very brave man to choose a PCI as a revascularization method for this patient, because in my own opinions, bypass can be considered as the first option of that patients. So because of the limitations of times, I would just have a very quick question to all the panelists. So in case of last main vessel for the heart, is there options of an upfront IBP or upfront impeller for the colleagues in US to do the case to make it safer? So we want to hear from Dr. Pinto and also my good friend, Dr. Kumar. He's now online now. So please have your opinion sharing if we have MCS upfront before a very, very high risk procedure.
Yeah, it's a really important question. I think a question that is a lot of controversy, and we don't know the truth. We have a luxurious situation in the United States that we can use it if we deem necessary. I'm interested in the ongoing trial Protect 4 that's randomizing patients with very complex disease and reduced ejection fraction against Impella versus either nothing or balloon pump. There are certain cases that I've not been able to do were it not for an Impella, that the patient was non-pulsatile for most of the case, and they got very sick. They would have been with a blood pressure of 60 for an hour or two. And I've also had patients who died on the table from hemodynamic embarrassment after during the PCI because we couldn't support them effectively. That doesn't mean that we have to do mechanical support in every case where it's complex. And I tend to not use it simply because someone has a reduced ejection fraction and complex anatomy. They have to have some evidence that either they are in heart failure, elevated filling pressures, and or reduced cardiac output. And then if I'm going to rotablade a very extensive area, and like in this case, the anterior wall, I will be more free about using an Impella. So I don't know what the ejection fraction was in this case or whether the patient was compensated before, but you can see the extreme stress on the patient and the operators that happened when the patient's left main dissected. And that, would be a very stable situation with an Impella in, and you would have more time to think and to deal with the problem. Now, obviously this case turned out great, but I don't know that every single one and every single operator in this case would be able to accomplish what was accomplished here. So it's a long answer. I didn't give you an answer, but it depends, and I await the results. Again, I think for practical reasons, most of the world is still going to have to do the cases the way that they do it, because I don't think a $25,000 device is going to be practical for most cases.
Thank you, Dr. Pinto. So, Dr. Kumar, any idea about MCS for that kind of PCI?
Thank you. This is a very complex lesion. And without really knowing what the ejection fraction is, I am assuming it is possibly low. And given that, and the extensive atherectomy that is required in the left main, well, in the proximal LAD and distal left main, ostial, I would say left main bifurcation, I think I would have erred in favor of mechanical circulatory support in this case, but then again, that is with the power of hindsight. I recognize the fact that this is a $25,000 device, and this is not something that is available. Now, even if we can say we're going to take the cost of this device and put that to the side, and we are not going to, in a dream world for a second, if you follow me and say, okay, we are going to be in a dream world. Even in a dream world where cost is, let's say, not really an issue, the access complications from the impella, the vascular, whether the iliacs are adequate, access site complications, all of these issues also add on. And so, we need to consider that as well. And, a lot of these considerations need to go into play in terms of some of these cases. So, yeah, it is not easy. And it's, I think I would have erred in favor of having a mechanical circulatory support device. But again, I can understand it can go either way in these kind of cases.
Thank you, Dr. Kumar. So even in our dream world, we still have problem. Okay. Okay, so let's move on because of the limitations of time. So I want to introduce my close friend, a famous operator in not only in US, but also in Asian area. So Dr. Gautam Kumar, he will talk about optimal PCI and complex PCI. So please, Dr. Kumar.
Thank you very much. Are you all able to hear? Okay.
Yes,
great.
yes, Gautam.
Okay, perfect. All right. So the thing about optimal PCI and complex PCI is that the problem is this. We do know that from all of our practices and from the cases that we are seeing here, that anatomic and clinical complexity in patients with CAD is increasing. That's a given. You know this, and I know this. Complex CAD has not been very well formally defined, but we do know that it includes both anatomic parameters and clinical parameters. Now, these may interact to increase the risk of complex PCI, and this may also create problems for us in terms of compromising the outcomes of optimal PCI. So if you look at this Sky paper on complex PCI, they have this ACE classification, which I think is an interesting framework to start with. You have stable CAD without complexity, A, and you have complex comorbidity or complex PCI. Complex comorbidities being defined by ACS, low EF 30%, heart failure class 3 to 4, CKD, severe anemia, severe contrast allergy, severe aortic stenosis, coexisting PAD, recent TIA, stroke, coagulopathy, pulmonary hypertension, or lung disease. Now, complex PCI generally is defined in this subset as SVG, unprotected left main, bifurcation with severe side branch lesion, severe calcification, CTO, MCS, coronary thrombosis, 3-vessel PCI, last remaining conduit, or severe tortuosity. And I think some of the cases you have presented meet all of these definitions. And then, of course, in the E classification, a lot of these are actually patients who have cardiogenic shock or cardiac arrest, which is a very difficult situation. So if you look at the anatomy alone in complex PCI, you have diabetes mellitus in terms of comorbidities, CABG ineligibility, CABG turndowns being fairly common, cardiogenic shock, valvular heart disease, acute coronary syndrome, renal insufficiency or dialysis, and impaired ventricular function. So these are the parameters that we have to consider. Equipment-wise, we have to think about atherectomy. We have to think about having covered stents on the table, intravascular imaging, specialty coronary wires, usage of coronary physiology, guide catheter extensions with GuideLiner, GuideZilla, and other guide catheter extensions, embolic protection devices if necessary, especially for vein grafts, and mechanical circulatory support, flavor of which, depending on what is available and what is feasible. Now, in terms of the anatomy, we have to think about multi-vessel CAD, calcified lesions, left main disease, bifurcation lesions, in-stent restenosis, CTO, and saphenous vein graft disease. So that's the complex anatomy that we're dealing with. So you have anatomy, comorbidities, and equipment, also ACE for complex PCI, okay? So when we start thinking about complex PCI, what is the first thing that we start off with? we start off with, okay, pre-procedural assessment. What am I going to do to assess this patient? Okay, so first thing in your pre-procedural assessment is the clinical judgment. Now, clinical judgment, as our seniors know, it is very crucial in these patients. It is important to, as Dr. Noor also mentioned, I think it is important to gain, we can gain some surrogate clinical judgment from our senior operators by asking for their clinical judgment as well. And that can be sometimes helpful in some of these cases. There are scoring systems that are available. The STS score, Euroscore, and the NCDR score are scores that look at clinical factors that the patients have. And these generally pertain to surgical risk. And they may tell you whether a case can be a surgical case or not. The Syntax 2 score is a useful score because it looks at clinical and anatomic score. And if you integrate it with the functional syntax score, it includes physiologic results as well. It is important to have a hot team approach if a surgeon is available to have them discuss and look over some of these cases. Acute coronary syndrome is always a difficult scenario because that takes away the limit of time that we have. Because if we have acute coronary syndrome, we tend to prefer that those patients are treated expeditiously. If it's a STEMI, for example, you will need to treat them ASAP. If it is an NSTEMI, which is high risk, we would still like to treat them rapidly rather than delay and delay care for this patient for several weeks, for example. Impaired LV function and shock is a very important scenario. CKD, diabetes, and concomitant valvular heart disease. These are things that you think about in this scenario. Now, with aortic stenosis, for example, with TAVR, you can think about whether you need to do the valve first or whether most patients can get away with just getting the valve done and then think about revascularization CAD afterward, or you may have to think about doing CAD revascularization first. There is some early data about getting it done in the same setting as well. Now, in terms of circulatory support, there are multiple different options that exist, both for right-sided ventricular support, which is on the left side of my screen, and for left-sided ventricular support, which is on the right side of my screen. So we will start with left ventricular support. Probably at the most complex level, there is tandem heart, which provides maximum output of about 4 liters per minute, and it's a continuous flow pump. Large cannulas are involved, including you may need to put in a transeptal cannula as well if you need to do that. Now, if you're going to do with Impella, it is generally arterial sheath, and most of the Impellas can go in the cath lab, and they can put in through the femoral artery or axillary artery, which can be a very valuable conduit in these patients in which there is significant iliac disease. The axillary artery can be a very valuable conduit. Intra-aortic balloon pump is still a very important adjunct for complex PCI. Some of its abilities have been questioned, but however, it still remains as a very important tool in our armamentarium. VA ECMO always remains an important part of the armamentarium of patients where you need more support that may also require right ventricular support as well. And finally, on the left side of this, there is Impella RP, which is the right-sided Impella device if you just need right-sided support, which is a little more unusual for PCI patients. Now, in terms of complex PCI, we need to think about what we want to do for the interventional treatment of complex CAD. So the first thing to think about is how are we going to plan this case? We will think about what is the arterial access, whether we are going to be radial, whether we're going to be femoral. Now, in the old days, we would say that, oh, you can't, if anything that's going to be more than 7 French, you will have to go femoral. That is not necessarily true anymore. There are dedicated sheethless guides that are available that are 7.5 French that you can use from the radial. And if you don't want to use the sheetless guides, there are inadequate large radial arteries. You can go with a sheetless 7 or 8 French guide catheter, which may also do the job for you as well. So there are multiple options with radial. Ulnar artery remains an attractive option, especially in those where radial artery may be diminutive. Ulnar artery is also an attractive option. In terms of femoral artery, it is important to familiarize yourself with micropuncture access, ultrasound guidance, and fluoroscopic guidance for obtaining access to ensure that access sites are good and you don't have a high stick or a low stick, and preferably you're able to close these. Peri-procedural anticoagulation for these patients, we generally tend to prefer unfractionated heparin because it is cheap, it is available, we can monitor it. ACT of 250 to 300 is probably suitable for most cases. Between 300 to 350 for longer retrograde CTOs, sometimes for extensive atherectomy, you may also want a slightly higher ACT as well. Our DAPT, we generally load all of our STEMI patients and ACS patients, and in patients who come in for planned PCI, we tend to load them for DAPT as well before the procedure. Because after the procedure, we don't know how their condition will be. They may be having some nausea, vomiting, etc., and we may not be able to load them on DAPT after the procedure. So it's probably a good habit to get to do that upfront. Coronary physiology, it's an important factor. The importance of coronary physiology is cannot be underemphasized. It can be incorporated into the syntax score. Like I discussed, it can be shown that it also decreases the number of stents and improves outcome. So this is a small analysis by Zimmerman, published in European Heart Journal, where they basically looked at a patient level analysis and found that FFR guided therapy actually has a decreased risk of death or AMI compared to medical therapy. Now, in terms of coronary physiology, you have multiple different options that are available to you. If you want to do hyperemia, you have FFR, which is a tried and tested and available. You can do contrast PDPA if you just want to have partial hyperemia. And then you have, take your pick, the different softwares that are proprietary to the different organizations, IFR for Philips Volcano, RFR for Abbott, and DFR for Boston Scientifics. And so you have all of these that are available in the systems, and you can use these with a cutoff of 0.89 as well. Now, it's important to realize, especially with data coming from the defined PCI in this trial, that nearly about 25% of patients ended up leaving the cath lab with an post-PCI IFR of less than 0.90. So let me repeat myself. The patients had PCI and they left the cath lab. 25% left the cath lab with suboptimal PCI. So this is a small plug for thinking about post-PCI physiology in some of your patients, because what you don't want is to have the patient come in and then go home with an IFR that is still not above the cutoff. So now, do we know whether going home, getting an improvement, a delta IFR, and going home with IFR that is still above the cutoff, does leaving that be as it is, does that affect symptoms? Does that affect outcome? We're still, we're still trying to find that out. That is part of the ongoing defined GPS trial. And this is the same data from the FFR search study that looked at patients leaving with an abnormal FFR. And again, in this study, this used FFR. About 37% of patients had an FFR of less than 0.90 post-PCI. They had higher MACE, higher cardiac mortality, more MI, and more revascularization. So we do have some outcome data here on these patients. So it's worthwhile to think about post-PCI physiology in some of these complex PCI patients. And this may, at the end of the day, result in longer stents, or you may need to do more stenting, more complete expansion, more plaque modification in order to ensure that you have optimal results. Intravascular imaging is always very helpful. It is, I wouldn't necessarily say that intravascular imaging is an option for complex PCI. I think it is essential for complex PCI. This is being elucidated further in the ongoing IMPROVE trial in the United States. Intravascular imaging resolves ambiguity. You can assess plaque burden, calcification, and you can optimize PCI with accurate vessel sizing and maximal stent expansion. In general, you can look at IVES versus OCT. This is a study that looked at all of these, and you can see that in general, most of the things tend to favor the left side, which is intravascular imaging is beneficial. Now, let's quickly talk about calcium and plaque modification. You have multiple different options for calcium and plaque modification. Broadly speaking, you have rotational atherectomy, orbital atherectomy, shockwave lithoplasty or lithotripsy, and laser. So these are all the different techniques that are available. Some of these techniques are available in your geography. Some of these techniques are not available in your geography. So it is going to come down to what you're familiar with, what you're comfortable with, and what you can use. A couple of key things to remember: it may not be possible to cross every lesion with a shockwave or a laser. Typically, it is probably good for most operators to be facile with rotational atherectomy, because it is going to be at least important to create a pilot hole with the rotational atherectomy catheter, so that you can then use some of the other techniques. You can do rotoshock or razor, for example, to kind of enhance your plaque modification if necessary. That is a more cost ineffective approach. If cost is a significant issue, you'll have to think about rotational atherectomy followed by balloon angioplasty. Specialty balloons like cutting balloons do have significant value in this scenario. In-stent restenosis is a iatrogenic disease. As interventional cardiologists, we can take pride that we created this disease, in-stent restenosis. It did not exist before interventional cardiology came around. Typically happens between about 3 and 12 months of post-PCI and about 2% per year after the first year. Risk factors include diabetes, vein graft disease, prior ISR, underexpanded stents, and high total stent length. Intravascular imaging is essential to identify the mechanism. I noticed that in one of the earlier talks, we were looking at the Waxman classification. That's an important classification to look at the mechanism of ISR. One layer of DES with lesion prep. A new DES is generally preferred. With 2 layers of DES that are already there, balloon angioplasty, drug-coated balloon, IVL, brachytherapy, these are all different options that have been used. Vein graft disease is high risk for distal embolization and peri-procedural MI. The outcome is poor both for DES and BMS. Native CTO PCI referral is generally preferred in expert centers in this scenario, and prolonged DAP can be of benefit in these patients. Bifurcation lesions are about 15 to 20% of all PCI lesions. The Medina classification is most commonly used. In general, if you don't have disease that extends beyond 5 millimeters past the side branch, probably the preferred approach is provisional side branch stenting with POT. Now, if you have significant disease that is going past the side branch in a 1-1-1 pattern, typically then you may need to consider other alternatives. Again, physiology here can be of value. It's worthwhile thinking about doing a physiologic measurement of the side branch, and the flow is good. Probably leaving it alone is a reasonable option as well. Left main coronary artery disease is found in about 5 to 7% of diagnostic CATs. 80% involve the bifurcation. Long-term outcomes are actually comparable between CABG and PCI, provided that the syntax score is less than 32. However, PCI is associated with higher rate revascularization. But you know what? Most of our patients may not want to have surgery. They don't mind coming back to have an additional PCI. That may not be a bad deal. So we are still in business. Liberal use of intravascular imaging and 2-stent bifurcation techniques for complex bifurcation disease is essential. Now, in terms of CTO, the prevalence ranges about 18 to 50%, depending on the study population. CTO PCI does improve the quality of life, that is known. Planning is essential for CTO PCI. Dual injection is an important part that should not be underestimated. Lesion crossing, these are your 4 major techniques: antegrade wire escalation, antegrade dissection reentry, retrograde wire escalation, and retrograde dissection reentry. Meticulous recent prep is essential with imaging prior to stenting. So again, that's basically a summary of CTO PCI. So finally, long-term management of these patients post-PCI. It's important to have them on guideline-directed medical therapy. It is very important to optimize risk factors, especially diabetes mellitus. Longer-term DAPT is preferred in these patients. Complex PCI will generally require more than 6 months of DAPT. There is an option of dropping aspirin in patients with elevated bleeding risk. Some of this is from the Twilight trial. And DAPT decisions may be needed to be made using the DAP score or the precise DAP score, which I would encourage you to look up, and this can be used to actually make decisions about DAP. In conclusion, complex PCI is actually becoming more common. We need to be facile with the multiple aspects, procedural techniques, careful follow-up in these patients. Continuing education is going to be essential, and process improvement plays a vital role in serving these patients. I would like to take a second to thank my very good friend, Dr. Tak Nguyen, for inviting me, and also Professor Ho, Professor Nguyen, Dr. No, and of course, my good friend Hui, for inviting me and having me at this conference. Thank you very much. Please, if you have any questions, go ahead.
Gautam, I have a question. You mentioned about the post PCI FFR and how we're often leaving patients behind. And what I found in my post PCI FFR with IFR pullback or resting index pullback is it's very often diffuse disease. And it's not necessarily the stent, but disease that was angiographically inapparent. And you know, I always feel, you know, bad when I leave a case like this, but should we be putting in longer stents? Should we be making the FFR or the resting index 0.89, or should we be leaving the disease alone? You know, it's always a conflict.
So Dwayne, it's interesting because in defined PCI, it was 1/3, 1/3, 1/3 in the patients who had abnormal IFR post PCI. 1/3 of them were distal to the stent, 1/3 of them were within the stent, and 1/3 of them were actually proximal to the stent. Now, the within the stent, you know, you can say, okay, that may be amenable to more extensive lesion prep that may have something to do with it, that could have helped. The distal to the stent and proximal to the stent, you're absolutely right. There is probably more extensive diffuse disease in the vessel. And those of us who use more IVUS, we're able to identify this. And you see this all the time. Does going longer in terms of your stents, it does carry a hazard of restenosis. Over the years, you know, I've found myself in my practice doing what is called stent creep, where I notice my stents are getting longer and longer. And I'm not sure whether that is correct, but it seems like when I first started, I used to say, oh yeah, there's the lesion. Let's just put a 12 millimeter stent and cover it. Now, you know, I think months go by that I don't even use a 12 millimeter stent. So, you know, I get your point. But yeah, I think that's a reality that we're working in.
So, Dr. Kumar, can I ask you a question about the physiology guided PCI? So, what is your opinion about the target study that they use the FFR to guide the PCI? And then finally, we have the result that based on the Seattle Angina questionnaire. So the patient is still the same between the two groups. So what do you think about that?
Well, that is a complex issue. I don't have a great explanation of that, unfortunately. I don't really have a great explanation as to why that study found that. It's just in most other trials, FFR has been shown to be beneficial and even has mortality benefit. You know, if you talk about FAME and FAME2, but I'm not absolutely certain why we ended up having this result.
Yeah, thank you.
Gautam, the stent design. So, is there any difference in between choosing this stent over that stent affect the procedure success? Because nowadays we see a lot of improvement in stent technology. We have thinner stent. We have a lot of advantages in the flexibility, the pushability of stent. So then, how is your own experience in choosing stent for complex PCI?
That's a great question. It's actually a very complex answer as well. In the United States, the way it is, and this may be the same way in most of your labs as well, we may not have a choice of every different brand of stent that there is on the shelf. You know, it may be what the hospital has the contract with that is available for you to use.
Yeah, yes.
So, you know, you have to be facile with the equipment that you do have. The good news for us is that most of the drug-eluting stents from the common manufacturers, you know, Boston Scientific, Abbott, and Medtronic, they're all fairly comparable products that have, you know, durable drugs. And I would say Synergy being a biodegradable polymer, but the other two being durable polymer drug-eluting stents. I have found all three of them to be reasonably deliverable. There is one advantage of the Synergy where you can have the 48mm stent that is available in the United States. I don't know if you have 48mm available in Vietnam.
Yes, yes, we have.
Yeah. Do they have 48mm in any other brand in Vietnam?
We have I think some 48 Zines also.
Okay.
And, yes, some of the stent company from India, they also provide us a long stent. I think the longest stent available in Vietnam is 60mm stent. Yes, I've never used. I have no idea any experiences of a 60mm length stents. So any of you, Dr. Hung, Professor Jung, or Dr. Quang, any of you have experience with a very long stent like that?
Yes.
You know, Dr. Hui, I actually have a controversial point is we don't need better stents. We need better doctors. And the stents are so good now that we get them to places where they shouldn't go. We get them into very distal arteries, 2mm arteries. And when we compare one stent to another, there's a fraction of a percent difference in TLR, or we may perceive something with delivery that we overcome with a guide extension or something of that sort. What we need is people to not put in underexpanded stents. What we need is people to do a better job. And whatever stent we pick, these current generation of stents have done really well. I think the stent companies want us to believe there's a big difference between one stent versus another. But all of these stents, from the Indian stent to the Chinese stents to the American stent, whatever it is, they're now all very good. They are all very well engineered. The engineers are smarter than us. But in the end, we need to do a better job with the proximal LAD if we're ever going to beat the Lima. And that involves all of the things that were talked about in this session, not a different brand of stent.
Absolutely. It's not the stent. It's really going to be the lesion prep that we do, the post lesion, the imaging, it's going to be everything coming together. Absolutely, Dwayne.
Dwayne, you are the moderator.
Okay, well, so Gautam, thank you so much. I appreciate you and your talk on a very comprehensive review of complex PCI. That was the fastest review of CTO PCI that I've ever seen. But I think that discussion now, we should move on to our next speaker, who I think is Dr. Tak. Is that correct, Dr. Tak?
No, it is Nguyen Hung from Cherry Hospital.
Sorry, who is?
Next speaker, Dr. Nguyen Hung.
Yes, thank you.
So is yours Dr. Hung?
Yes.
Or who is
yes.
it?
Yeah. Can you?
So
can
CTO
you see my
PCI
slide?
is often complex.
Yeah. Can you see my
Okay.
slide? Yeah. Thank you.
Yeah. So I'm so excited to hear this talk. You know, we were talking that we first met each other now almost 10 years ago, and it's so glad to see your success.
Yes.
And I'm so happy to see you, and I look forward to your talk. Thank you.
Yes, thank you very much for the introduction. Hello, everyone from US and from Vietnam as well. Good morning or good afternoon is good evening. Now we just hear the hello, everyone. So I talking about the topic on the CTO besides the often complex one. Usually the often, usually the complex one, not always. So as we know that the CTO is quite different from the other lesions from definition, from the anatomy, from pathology, and of course the outcome as well. So why like that? So we, as we know that the CTO definition and its composition is quite different with the, usually we say that the normal or complex lesion, that the, at first thrombus formated inside, and then a couple of months later, it's become the collagen, rich with the collagen and calcium, and then a lot of fibrous tissue, proteoglycan, and then calcium a lot inside. So at first, very easy to do the intervention, but that after more than 3 months later, it's not easy to open it up. So this is the CTO body, as we already know from the more than 20 years ago. So this is the proximal cap. So usually we have to use the wire, the CTO wire, in order to pop this proximal cap in order to go through the CTO body. But sometimes we poke from the outside, we poke from the correct at the center of the cap, but after that the wire go by to the wall of the vessel. So that's the complex situation. So I just show the picture again for you to see. So as we already know that the when we looked at the CTO, when we come with the CTO patient, so we at first when we are junior doctors, so we do deal with this kind of lesion. For example, the CTO is usually around a couple of months from the index of event, and shock occlusion, long and stretch proximal segment, residual stump, taper, or the distal vessel visible via collateral. So quite easy to go through the CTO. But when we develop our careers, of course we have to cope with quite a lot of difficulty, and of course the easy one already opened with the junior doctor. So then we have to deal with the complex one. So for example, very tortuous, very calcified, breaching, collateral, a lot ambiguous, etc. So CTO itself is quite complex because with the patent vessel, so we see the course of the vessel easy, and we can put the IVI in order to see that the calcium inside or the fibrous inside or thrombus, but with the CTO, we don't know from the proximal cap. So that's the reason why it's complex. So for example, on the way, the vessel can make the curve like this or straight, we don't know. Sometimes we use the CT in order to know that the course of the vessel, but sometimes we don't use the CT, we just go straight, so we go outside and we make the complication. So for example, the vessel is tortuous, the vessel had a lot of bending, a lot of angulation from proximal to distal. So in this situation, we have to be very careful when we use the very strong wire, CTO wire, in order to open it. So and the last one is at the exit. So usually we have a lot of branches at the distal end. So we go wrongly outside with the CTO wire also. We make it a lot of difficult. So when we sit up together in order to write this consensus that this is the CTO trial, we see that the CTO guy usually have to cope with the complication, acute complication, and the outcome later on. So for example, in the acute phase, so we have to cope with about around under 1%, or sometimes we have to cover with more than 1% of patient that the patient develop tenderness after we do the procedure. On the rest is just the acute mind or something unwanted. So I go through some situation that we call that the complex. So for example, the CTO is quite easy based on the J-score, but not easy to cross because the very simple reason is just the guiding issue. So for example, this is the CTO. You can see this. This is the CTO of the mid RCA. Mid RCA, we can see the distal end with the bridging collateral and the tapering from the beginning of the CTO. So we can go through this, but actually this is already failed by another doctor. Why that? Why like that? Because the guiding catheter is not strong enough in order to get a good backup in order to do the CTO wire go through. So that doctor used the AL 0.75, sorry, AL 0.75 in order to get stronger backup, but the wire still hit the lesion proximal cap and bouncing back from the atrium of the RCA. So we have to use the ABU 3.0 in order to get stronger. And then this time it's easy to go through with the CTOY, and this is the final result. So from the beginning, we see that it's quite only the 2 points from the J score, 3 points from the J score, but not easy to go through because the guiding backup. So another situation is we not easy to cross because there are two TCO together, so we call the sequential CDO. So sometimes the patient had the very long CDO. The first CDO may be the original one, or the second one may be the original one, and the first one may be the new CDO one. So, for example, this guy is we have the CDO with the bridging collateral from the proximal to the second curve of the RCA like this. But the distal RCA is another CDO. So maybe this one is the original one, and maybe this one is the new one. We can go anti-grad approach, and we can finish the wiring to the side branch like this. However, the distal end, we don't know. We really don't know what is the curve of this one. So we have to open another. We have to use the guiding left guiding catheter in order to see the distal end. And we go from the left to the right and to wire mix at this point. So we connect together, and then we have the final result here. But anyway, when we open it up, so still we have the distal BDA still have the obstruction here, but this is too small vessel, so we don't do anything for this. We just use medication for the patient. Another situation I want to mention is the CTOY cross. However, other devices didn't cross because severe calcium. So this is the case of that. So this is the circumflex and OM. So we can see that the very severe calcified lesion, and the CDO body is very easy to measure. But we use the Gaia second didn't cross, so then we use the concave probe and cross the lesion. However, after crossing this lesion to the OM, so we couldn't pass through any balloon, even the smallest balloon 0.85 millimeter also didn't cross the lesion. So we use but anyway, the balloon can make the proximal segment taper, then the rotor wire can go through. And after about 6 times run, and finally this one is the final run, so it goes through the CDO. So this is the final result. We put the 2 stent for the patient, and we finish the procedure. Another situation that we have to cut is the ambiguous proximal cap. That's very easy to have the complication. Like this, you see a lot of small vessel at proximal RCA. And the distal segment of the mid RCA, we can see the vessel here. But the course from the proximal to the distal, proximal cap to the distal cap, we don't know. We really don't know that we go through and we can go outside the vessel, and we have the complication. So this is the anti-grad approach. So it goes to the small vessel and go to the bridging collateral. Of course, we are the one that thing happened. So we have to go until we cannot go, and then we use another from the left side in order to know that the distal segment, where is the distal cap. So actually, the distal cap is to here, and then make the curve, and then connect to the proximal end. Otherwise, if we go from the proximal to the distal, so we connect here and we go through outside like this. So that's the reason why sometimes we have to use the 2 guiding catheter, and then we have to go from the left to the right, or the right to the left, and then make the connection together. And this is the we do the dual guiding catheter from the left to the right, and then sorry, cannot work. And then this is the final result. You can see that, yeah, the curves come to here. This is a breaching collateral and small vessel like this. So if we go through, go straight, so it go outside like this. So the opposite side, guy Y go up here and make the turn here. So we know that this is the distal cap. So we have to stop here and can make the connection. So you can see on this this view as well. That's the reason why ambiguous and tortuous proximal cap is the dangerous for the CDO BCI. So another situation that we have to be very careful, and so usually we do the intervention and we have to engage the guiding catheter to the left main or to the atrium of the RCA. But this is the left main CDO from the atrium of the left main. So how to do that? And this is the patient with the hypertension, and of course the ascending aorta got dilated around 60 millimeters. So the patient had to be the patient undergone the surgery in order to get the procedure like this. We call the bento surgery. So they keep this sinus again, keep the sinus. However, after two years, the patient have the chest pain again, and we did the angio, and the left main already disappear. We don't know when. And of course, the patient have the symptom. So we have to go from the. I go back for you to. They put the 700 band for the LED only, and they keep the left main for the circumflex perfusion. So, but the patient now is get the stuck of the left main, so the patient developed chest pain. So the patient came to the cath lab with that symptom. So I use the 700 band graph, go here to the LED and go back to the left main, and I use the Concat Pro 20. At that time we have the Concat 20. Now we don't have the Concat 20 anymore. And in order to poke this cap and go to the aorta and then make the connection. So this is the CDO of the left main, and of course we open this for the circumflex, and the LED had got some flow to the mid segment of LED. And another CDO that we don't want to do, that the patient already had the underwent the aortic valve replacement about 8 years already before. But now the patient come back to the cath lab with the chest pain and dyspnea. So this is the angiogram, aortic angiography show that no left main here, just the RCA and with the good collateral to the LED and circumflex. So how to do this one? Of course, we have to go from the right to the left because we don't see any clue of the left main. So we have to go from the right to the left. And during the procedure, as I saw before, that the patient, I use the AL in order to get strong enough, strong backup in order to go from the right to the left side. But during the procedure, the patient developed hypotension. I checked the pressure, that the pressure from the guiding is okay, but the pressure is very low. So I looked at the picture that the guiding catheter compressing on the aortic valve like this. So I have to change the guiding catheter. So we go back to the JR. We know that JR catheter is not strong enough, backup enough, but we don't have any other choice because if we use the AL, it's sitting on the valve again. So, but we have to use the AMLOT with guiding catheter and stay away from the valve. So finally, we opened the CDO, successfully opened the CDO, and this is the result for, you can see here, this is left main, this is the LED and circumflex. And the final shot, yeah, quite good for the patient. and the patient have no symptom after that. Another situation that I want to mention is the sometimes we don't have the collateral from the retrograde. So how to handle a CDO already failed with the antegrade approach? So this is the patient with the acute inferior myocardial infarction, and we opened this lesion already. So another lesion is the CDO on the left side. So CDO on the left side, CDO from the LED, but the distal labment has minor disease. Circumflex also have the minor disease. So when we put the guiding catheter here, we try to go from the retrograde from the OM to the LED, but we fail. And we go from the right side, but the we don't have the good collateral from the right to the left side. So this is the I tried to go a retrograde from the OM to the LED, but the no epicardial collateral. So we don't know where is the proximal cap in order to poke, because if we poke without any clue, so we can make the complication. So I think of that we have to adjust the guiding catheter. So I use the technique. I named that the hanging and floating wire technique. So I put the guiding to the left main, another wire to the circumflex, and another wire to the aorta. So the wire from the aorta and the circumflex stop the guiding catheter sucking the left main. So the third wire is the functional wire. So the third wire is the functional wire. So we can go change the guiding catheter direction, and then we can change the direction of the wire, and then we find the proximal cap. And this is how I change the guiding catheter direction. And then finally, I use the Gaia second and successful poke the proximal cap and go to the LED. And you can see here that this is the final result. And of course, I use the right side in order to check the distal segment that the wire in good position or not. So another situation that we have to copy the no way from the antegrade through and through technique is the only one from the beginning. We don't have any other choice that we have to poke the ambiguous proximal cap, because there's so many small branches go to the distal CDO segment. So we try for a while, but we know that it go to small vessel and it can cause the perforation. So we have to combine from the left to the right side. So I use the wire from the left to the right, and then go up to the aorta, and then we use the snare in order to capture that wire, and then this is the final result without any role of the antegrade wire. So this is one of the situations that we don't want it happen, because we already go to the destination like this, but we don't want to. But we have to cope with the one that we really don't want. So is it to cross the CDO lesion? Is it to deploy the stent? But what happened? So this is the one, the kit like that. You can see that this is a very short CDO. You can see, and the CDO is around under 20 millimeter, and we can see the distal end. So based on the J-score, it's not the difficult CDO. It's easy. And we can see here another CDO on the right side. So this patient have two CDO. So I chose to open the LED CDO first, because we think that the large myocardium. So I use the micro catheter with the Gaia CDO wire, and then go through the CDO, do the ballooning, and you can see that we open the CDO body and the wire in true position. However, what happened? So this happened when we put the two stent, and then we do the ballooning post dilatation with the high pressure balloon. So a rupture here. So if we use the IVER, so maybe we know something, for example, bridging or something like this at this segment. So anyway, we successfully opened the CDO, but now the patient have the chest band on the table, hypotension, and we have to do something for the patient with this. So we use, of course, we use the balloon to stop the bleeding, and for around 15 minutes without any cover stand, the patient recover. However, we can see that some thrombus already formation at distal segment of the first step. However, the patient stabilized, and we can discharge the patient a couple later. So last year we sit together. About 2 years ago, we sit together and we give some comment in order to make the consensus that this is the key principle on the indication and technique of CDO PCI. So principal indication for CDO PCI is to improve the symptom. So if the patient has so much symptoms, so we have to open the CDO. Dual coronary angiography and through structure angiographic review should be performed in every case. Use the microcatheter is essential for the guide support. There are 4 CDO crossing strategy as I show of the next slide. Change of the equipment and technique increase the likelihood of the success and improve the efficiency of the procedure. Center and physician performing CDO PCI should have the necessary equipment, expertise, and experience to optimize success and minimize the complication. And every effort should be made to optimize stent deployment in CDO PCI, including the frequency use of the intravascular imaging. So with the last case like this, so if I use the IVUT, maybe I escape from the rupture of the vessel. Anyway, we already go through the complication without any consequence. So this is the four key angiographic parameter that we have to pay attention. That we have to look at the proximal cap. We have to look at the lesion length, the course of the vessel, and composition of the lesion as well, the distal vessel, and then the collateral. And this is the illustration of the CDO crossing technique. So I think that you already know this picture from the Dr. Prilakik, very famous CDO guy. So this is the global crowded CDO algorithm that I usually use this one in order to cope with the CDO when I do the procedure. So this is the take-home message from my presentation, that the CDO are the story of simple or complex lesion happening more than 3 months before. Therefore, PCI for CDO is often a complex procedure. CDO PCI are often complex and low success rate procedure. Good strategy, devices, and CDO team may increase the success rate and reduce the complication. And we should prepare for the complex ones until we realize they are not. Thank you very much for your attention.
Well,
Thank you very much.
That was incredible. Fantastic. I'm so proud of you, Dr. Hung, because I see that the change in practice at Chore Hospital of what things were like when I first visited 10 years ago to now. These are incredible cases that are remarkable for anywhere in the world. And so this is fantastic and in no small portion due to your efforts. So I'll turn it maybe over to Gautam to now take over as the moderator.
Yeah, thank you. Dr. Hung, those were fantastic CTO cases that you showed. These would be wonderful cases that would be excellent in any center. Now, I just had one question about that left proximal LAD CTO that you had. Did you consider IVUS guided puncture as a possible option in that case?
Yes, thank you, Dr. Kumar. Very good, very excellent question. That actually you can when you look at the left main and the circumflex that female patient. So if I use the IVUS, so it will stuck the circumflex flow. And we have to use the bigger guiding catheter, for example, 8 French guiding catheter, and to use the IVUS and then the micro catheter together. So we stuck the left main as well. So that I think I thought that but I didn't use that because it's too invasive for the patient. So I tried to use a simpler one. For example, I use my technique that I use the half technique, that are hanging and floating wire technique, and I showed to you that, and it worked quite well. I use that for the short left main circumflex CTO or the circumflex CTO and left main steel pattern. I'll use for the right side for the corner one and the proximal RCA. That I use my technique and I poke the proximal cap. Thank you very much for the very excellent.
Yeah. It's
really
a
like
very important and practical technique, and it's good for not even just CTO PCI. When you're having trouble wiring the LAD, just put a wire in the circumflex and see if you can help you keep the guide in and wire. But I actually got them. I'd love to hear your perspective. I actually find it very hard to use the IVUS. I mean, the CTO operators always talk about this and say, oh yeah, we're using the IVUS to where to puncture and stuff. And I find it very difficult, and I like to just use my hands. But maybe I'm behind. I don't know.
Yeah.
It is tricky. It is not entirely always straightforward to be able to see and do IVUS guided puncture. I think Dr. Hung is absolutely correct in the sense that it will require an 8 French guide to be able to fit all that equipment in there. And that does make the procedure more complicated. Access is more problematic. It does make things more difficult. But I think there are cases where I think IVUS guided puncture can be of value. We have done several cases where I think without IVUS guided puncture, we would have been totally in the wrong area. You had several beautiful cases where highlighting the importance of retrograde. And I think, the point that you made is very well taken, which is even with the best retrograde access and the fact that you have identified the cap, you have managed to reach the cap, you have managed to do, you have managed to do something like reverse crush and managed to get things, you have managed to do reverse cart and managed to get the 2 wires in the same plane. Even then it can be complicated. And even then, you may end up still having a complication. So, it is very difficult. CTO PCI is extremely difficult in the sense that, you can do it beautifully, have it all look great. And then like you showed in your last case, post dilatation of the stent, and after that you have the rupture.
Yeah. I mean, you mentioned Dr. Dung's strength, that perforation and being able to just do balloon angioplasty with a covered stent, that's strength too. That's, I mean, it's incredible save.
Without a covered stent, Dwayne, it was just prolonged balloon inflation.
I know, without covered stents to have that confidence, I mean, what are you going to do? I mean, it's incredible.
Beautiful work.
Thank you very much for your comment.
Yes, I think I appreciate your presentation, Dr. Robin. And I consider the interventionist like to do CTO PCI us fighter is very strong, fighter is very calm, and fighter very patient because it's a long journey to do the CTO PCI. I appreciate your presentation and your experience very much. I'd like to ask Professor Nguyễn Ngọc Quang, do you have some comment or some experience to ask Dr. Ngô Minh Hùng? Professor Nguyễn Ngọc Quang.
Yeah, I think this is a great talk, and I cannot ask him more. I think one thing is really important to facing when we do the CTO is the question is when we stop. We might thinking a stop before the procedure, because sometimes the CTO or PCI is only for our eye, it's not really for the patient. So we need to consider very much. And also during the procedure, sometimes when we do a lot of things and the reason is in, you know, like pending, and then we think that we need to continue, but the time is limited. So I think that we need to think stop. And I think the last thing is very important recently is more relevant is failing is not a stop for the procedure. Failing sometime in the first time is opportunity to success in the second attempt. So the new data from the Chinese colleagues showing that when you punctuate, if you still keep the, you keep, there is no complication like a hematome for the CTO lesion, and even you fail the second time, you have more chance to success. So I think that it is something new in the CTO area, and the question is when it stop is very important for us, and it is my comment for that. Thank you.
You know, I have a comment for that as the cath lab director. Is I've gained significant satisfaction in seeing the success of the younger people, and we scrubbed 2 CTO operators in our PCIs, and it doesn't have to be me. I don't do CTO PCI anymore. I am not as good as it as the other younger people. And the 2 people scrubbing, the 2 brains together, make better decisions. So the 2 experienced operators can decide when to stop. And is this too much? And they discuss, and the 2 experienced people thinking about this is better than 1. And I think that's what's special about CTO PCI, at least in our institution, is we scrub 2 attendings. We don't actually care about the money or any of that, the time or whatever. Is when those people decide it's time to stop, it's time to stop. But when those people decide it's time to continue, we continue. And I can't make those decisions because I'm no longer qualified for that. So I let them do their thing, and that's become very satisfying for me.
So
Thank you very much,
Dr.
Dr. Duong Pinto and Dr. Quang, that the very good comment on the CDO, because you are already deal with the CDO before, and even the Professor Quang also the guy, CDO guy. So I also pay attention on when to stop. But the procedure is too long, and the patient cannot tolerate with the procedure. We also try to stop, but I choose the safety for the patient. We stop, but the patient has to be on the good situation. That's the good important, because the next time we have to continue our work in order to finish the CDO. So I just tell us the short story about the stop the procedure. I have the CDO on the mid LED, and I use the septal to septal retrograde, but they open the proximal mid LED to the diagonal, and they keep that, and I go to the septal to septal. However, the patient cannot tolerate with the procedure. I have to stop that for about 1 week, and then I bring the patient back to the cath lab, and then I finish the procedure with the Q-Lord stenting to the LED to the distal LED, to make LED to distal LED. That the one of the thinking of the when to stop. And of course, our team get tired already, so we also have to stop. But they pay attention on the patient situation. The patient has to be very stable after when we want to stop. Thank you so much.
So we have also gone to the same model as Professor Pinto. Typically, we have dual operator scrubbed in for our CTOs as well. I think the fatigue for an individual operator is a very real thing. And Dr. Hung, I think you're also identifying that point. And I think Professor Quang also alluded to this. The fatigue is a very real issue for a single operator for some of these complex cases, especially if it is a 2-3 hour CTO. And there are multiple things going on in the cath lab. It is just not, you're working on the CTO, but you have to see, is the ACT being checked? Is the ACT therapeutic? Is the patient sedated? Is the patient moving? Are they preparing for the next step? Are they anticipating the next wire you're asking for? So it is very good to have 2 operators to manage these kinds of cases. And I think there is another important rule that should be the rule number 1 of CTO that is not in that AHA document, which is you should never do a CTO because you can do a CTO. Yeah. You should never do a CTO because you should do a CTO. You should do a CTO because you want to improve quality of life. That should be the goal. So if the patient has no or minimal symptoms or is doing fine with medical therapy, maybe they don't need the CTO done. So I agree with Professor Kwong's opinion there as well. But absolutely, it has extended our armamentarium. It has enabled me to take on lesions that earlier on in my career, I would have thought, oh, this is impossible, I can't do this. And I find myself doing those kinds of lesions these days relatively easily. And sometimes I look back and wonder, oh, we actually went through this crazy epicardial collateral, which I would have never thought of putting the wire down, 10 years ago.
Yeah.
And I'm sure your experience has been the same as well, Dr. Hung.
Yeah, thank you so
Okay.
much for your comments.
Thank you so much for the discussion on the very exciting topic, but we a little bit late behind the time.
Yes.
So thank you, Dr. Nguyen Hùng, and thank you, everybody. But now I would like to invite Professor Thật Nguyễn with the topic optimal and complete coronary intervention from fluid perspective. Please, Dr. Thật Nguyễn.
Thank you very much. And you can see my slide, right?
Yes, slide clearly.
Okay, very good. When I do cases, I love to do cases, and the reason because all the time I have questions. Why we could advance the wire, why we could not.
Dr. Tak, your microphone, I think, is quite soft.
Yes, we are not able to hear. It is very soft.
Wow. Better now?
Yes.
Yes, much better.
Very good.
Okay, so we use it. No earphone. So I love to do cases because we have questions. How could I advance the wire? How could I advance the stand? How could I? The important. It's more important than the procedure by itself. At this stage of my life, I love to do cases, but for question only, for scientific research. And I used to use the hydraulic to explain what happened in coronary arteries. And I know today here we have Gautam. You are faculty at engineering school in Atlanta. Let's see. Okay. And I present this paper, this data, to my friend in Boston, and they are quite surprised about the result. So this is why I'm very happy. So the first one it is, when we see that the first one it is, how do we know that we did a good job after PCI? We can adapt the usual anatomy, or we can, for my part, I look at laminar flow. And then the second question is, can we change anatomy? We see the Chicago changes the course of the river. And in my lab now, we use a lot of IVL before stenting. And I have a few questions. I have weak point because some we could not explain it. Another part is, in our lab, we use a lot of impeller. So when we use impeller, we can do complex cases easily. We can stand there, we can finish it, we can try, we can have a rotoplator, we can have IVAS, we can do IVL, and at the end we have very good, we prepare very well the artery So when we stand it, it's wide open and beautiful. So the first question it is all the time, the first question it is, yes, we like to keep the original anatomy. Like in this case, the right coronary artery, and we put a stent, we did not disturb the anatomy of the artery. And we believe that in nature, if we keep the natural anatomy of the artery, it may be a good job. This is the number one. But in my part, I pay attention more about the anatomy and the laminar flow. Now, in the picture one, the artery is full with contrast. And B, at the white arrow, we see the flow coming in white color. And here we see in C, we see the blood coming in white color. And here in D, the blood arrived to the lesion area at the end of diastole. Now we go to the next one. In E, we see the flow go further in systole, but we have the contrast stay on at the mid segment, and it is turbulent here because the flow was disorganized. And then in G, we have the same thing, disorganized flow at the mid segment. And this is before we put the stent. Now, after that, we put the stent. In picture A, nicely. In B, we look at the flow now. And C, we see the flow. And D, we have laminar flow across the stent, across the lesion. We don't see the disorganized flow at the mid-segment like before. And this is the beneficial mechanism of stenting. We change from disorganized turbulent flow to laminar flow. Now in E, we see forward, and F, further, and G, we have some reverse flow here, and we have some contrast backward here. And this is the rule. I said, oh, no, this is the rule, but what I'm looking when we see the laminar flow. In the talk of Gotham, you mentioned that did we reverse the IFR to the normal level? The IFR is the formula is the distal pressure above the proximal pressure. If the flow is fast and good, that means the pressure is low. So the laminar flow can be a surrogate metric for pressure. Okay, so this is what I'm doing in research. Now, in the second one, it is here. I remember this case, and I kept thinking about that for the last 10 years. We look at the right coronary artery. It's so tortuous and strange looking. And then after the stent, come back normal. And this patient was stable, had no heart disease, no readmission for CAD for the last 10 years. So I see that if we can reorganize, we can restructure the anatomy of the artery, and we provide a good flow, we are okay. I see from my clinical experience. And here it is, I remember about the river Chicago, the Chicago River. At first, it was curved. You see here, it's curved, and it is very close to downtown, it is in downtown area. And in 1926, the city of Chicago has to straighten the river. So because they don't have too many bridges across the city. And here they make a cut, like It's the same like when we do angioplasty. And now here's the Chicago River. It runs very nice, beautiful, no problem. So I see that because many times, especially in bifurcation lesion, we change the anatomy, the natural anatomy of the coronary arteries. And here it is. This is the case, I take a picture from the internet, but in our hospital now, when we see the patient have a lot of calcium, we use IVL right away, lithotripsy. We don't have the balloon angioplasty. And I see that after we put the IVL, we can expand the stent very nicely. We can provide a good flow, a good laminar flow after we use the IVL. And this is the number 4. Even I love to look at the hydraulic fluid mechanics to explain the way how we do stenting. And laminar flow is the best flow, but I see that if the patient have underexpanded stent, the patient still have laminar flow. This is what I have the problem now. Number 2, laminar flow is not relevant in proximal lesion. Let's say, for example, osteo lesion. The osteo lesion you see is not because of the turbulent. It's not because of the turbulent flow causing by different reason. It's by the anatomy. And laminar flow is not relevant in bifurcation lesion. I saw many patients after bifurcation lesion. We look at the laminar flow is good and beautiful, still have restenosis, and laminar flow is not relevant in instant restenosis. I saw patients with instant restenosis and still have laminar flow. So this is a weak point in my research now. We have to see how to solve it. And here it is. Let's say, for example, now the picture A. We see why this patient has the lesion in the proximal RCA. And the mid RCA, the distal RCA is clean. It is all due to anomaly of the ostium, of the orientation of the proximal segment. Similar in this patient, in B. This patient has lesion not because of the distal flow, but it is because of the anomaly of the coronary ostium. And at the end, I conclude my talk. Number 1, I mentioned that we do a lot of patients with impella now in our hospital for 2 reasons. Number 1, for us cardiologists, we have time and we can stay long to finish the case, and we can do better care, better flow. 1. Number 2, the impella case, the reimbursement for the hospital, it's 4 or 5 times a regular case we do without impella. So the hospital is very happy that we do an impella. Number 3, I mentioned that in a patient, in a normal case, in a simple, easy case, we try to keep the anatomy of the artery. And I look at the laminar flow, we restore the laminar flow after the PCI. And number 5 here, that if we have to change anatomy and we can restore the laminar flow in the artery, I believe that we are successful. And at the end, the new way we do now, we do a lot of IVL, lithotripsy, and we put a stent. And I see that we have bigger lumen, we have better flow, and I see that we have so far low instant restenosis because we could expand very well the stent. And these are my weak points in my research we have to solve. And thank you very much for your attention. Thank you.
Thank you so much, Professor Thật Nguyễn, with the very excellent presentation. As we have here the new theory, new concept from Dr. Thật Nguyễn many times. But I think today I think that your presentation today have some the new explanation, but we know for a long time we explain atherosclerosis cardiovascular disease plaque with the theory mechanism due to LDL cholesterol and recently inflammation to make the formation of atherosclerosis plaque. But Dr. Thạch Nguyễn give the very new theory, a new concept to use fluid dynamic or fluid mechanics to explain how the disorganized blood flow or turbulent blood flow can help to form a blood flow. And today he give how we can assess the optimal PCI to assess the restore of the laminar flow in after stenting. Very excellent. And I like to hear some questions, some comment, or some discussion from panelists about the new theory of Dr. Thạch Nguyễn. And I hope in the near future we have the application of this theory in the clinical practice. Dr.
Gautam first, please.
Gautam first.
You are faculty of the School of Engineering.
Yes, so you are stressing out my thinking at 11:30 p.m. at night with all this very complex theories. It is very easy to do STEMI at 11:30 at night, but not very easy to do to think about laminar flow at 11:30 at night. But yes, I think you have hit upon several important points, which especially that, laminar flow, number one, is a very important point, and restoration of this laminar flow is an important part of what we do as interventional cardiologists. Now, how we restore it and the limitations that we have with that, I think that is going to be a great challenge in this area. So you have highlighted some important points, but I think we may need to do a lot more research to understand some of this better. And Tak, as you know, I have always said this, you're always many years ahead of everybody else in terms of thinking these ideas. And sometimes it takes time for the world to catch up with some of these things.
Thank you, Dr. Gautam Kumar. And the next, I'd like to hear some opinion from Professor Nguyễn Ngọc Quang.
Thank you very much, Professor Thạch, for the great talk again, as usual. So I think that we always think about the anatomy and also the flow, similar like the physiology of the blood vessel. And long times ago, when we do the PCI, we usually follow the principle that the bigger is better. And sometimes we post dilate too much, and then we see the flow got a problem. So at that time, we think that there is an interaction between the flow and also the diameter of the vessel. And now Professor Thạch give a new example about the benefit of the IVL, and then we can increase the size of the vessel. But the problem is, if we don't keep the interaction between the diameter and the flow, and then we might have a problem with the flow. And that's why also for the bifurcation, when we don't see the laminar flow is relevant, just because there is a lot of side branch, and then there is an exit point for the flow. So that's why the laminar flow is not relevant for the bifurcation. And I think that for the this theory from Professor Thạch give us a new concept, how we optimize and how we calculate the interaction between the diameter of the stent and the number of the side branch open after we stenting, because these keep the interaction between the vessel, the anatomy, and the physical by the flow. So this is something like the new concept appear, and I just give some comment from my side. Thank you very much again for the great talk, Professor Tai.
Okay, thank you so much. A very interesting opinion from Professor Nguyễn Ngọc Quang. And I'd like to invite Dr. Ngô Minh Hùng. You often have some opinion and some very interesting question. You open microphone.
Yeah, thank you very much, Professor Dũng. So I just had a short question for Professor Thạch that I love this theory. Actually, Dr. Kumar just mentioned that how do we apply that for sure in the future. So I think that Prof Thạch going to presented about the software, about the deep learning, how to calculate the lamina, and we for example virtual standing. Is this correct, Professor Thạch?
Yes, thank you. Usually very simple. You know that I was in Boston 3 weeks ago, and I present this data to our friend and one of the doctor who came to Jerai, Michael Gibson.
Yeah.
And he was very impressed with the data. And he asked me, did you publish it yet? So I said, oh, we are waiting for you. And so right now I am finishing the manuscript, and he will be the senior author, and we try to submit for publication. It's all about what we just discussed, about the laminar flow. And today I did a case, and you know that just let you know that your group does a lot of cases, and all the time we have to ask questions. Why it doesn't go, why it go, things like that, you see. And so I have a case. So usually we have the collision side. The collision, it is because of the antegrade flow collides with the retrograde flow. So usually it is a mid segment of the RCA. And this patient, and it is past the mid segment. I think why? I reviewed the chart. The distal RCA too long. So when the reverse flow goes back, it could not reach the RCA, the mid RCA. It reached only the junction between the mid and the distal segment. And this is where the lesion is. Very interesting. Yeah. So it depends on how long and where the retrograde flow can reach. And in this patient, the distal PDA too long. So it could not reach the mid RCA like a usual. It's called the distal segment. I really love it. And we see very clear. So this is one of the new explanation. And I show that what are the limitations of my theory. You see, we cannot explain about the proximal segment. We cannot explain about the bifurcation. We cannot explain when we have an underexpanded stent, and we cannot explain when we have instantary stenosis. But this is research. If we raise the right question, then we have the right answer. If we ask the wrong question, we have the wrong answer. That's all. Okay. So again, one more. You remember I talked about this one 3 years ago. Yeah. At that time, the data, the idea, the hypothesis were very basic, and people complain about that. So I listened, I came back and refined the idea, refined the theory, and refined the research. And this is how we arrive at today. And this is research. I gave the question I presented today, not just present all the success. I present also the limitation and listen to the comments to change to help to refine the theory and the hypothesis. Thank you very much.
Yeah, thank you.
Okay, thank you so much, Professor Thạch Nguyễn. I think certainly you have the long journey to go and many things to discover. But by now, your theory, your new concept are very promising, and you have already proven many things in your theory in coronary artery disease. Thank you so much. And by now, we move to the next topic today is optimal PCI in the complex PCI, not only to get success, but we must do in safety. And to do safety, we need mechanical circulatory system. So I would like to invite Professor Nguyễn Ngọc Quang with the presentation role of the mechanical circulatory support in complex PCI and how we do in Vietnam. Please, Professor Nguyễn Ngọc Quang.
Thank you very much. And the next talk, I will just give some overview about the mechanical circulation support for complex and high-risk PCI. I think Dr. Kumar already mentioned in his great talk. So I just discussed few things involving the data and what we can do for our patient. So basically, the first question that came in is how to identify the complexity and risk for PCI, because not every case is the same. So basically, we have a paper from British Cardiovascular Intervention Society database for 10 years and about 300,000 people, and they do analysis and see what the factors for the complex and for the event after the procedure. So they do quite a few things, and they put things into the CHIPS factors and calculate that, and you can see here this is a quite good data involved in each factor for that. And this is a number of the CHIPS score, and if we put everything into the one score and we calculate the cumulative percent of the case with that one, you can see if the CHIPS score increasing, the mortalities, the major bleeding, and also the cumulative procedure complication increase accordingly. So after that, they give out the score talking about how we identify the complexity and the risk of the procedure based on the patient factors and also the procedure factor. You can see here the age more than 80, female, priority of stroke, MI, PAD, LV function is less than 30, and CKDs, and also the factor involved in the procedure like a left main, PCI, three vessel disease, dual artery access. It means that the CTOs and LV mechanic support and the lesion length is more than 60, and also the rotablator. So basically, all the thing is combined into the one score to identify the complexity and the risk of the PCI. And when you see the number of cases increasingly, we see that very clearly that the CHIPS PCI become more prevalent. Also, the same thing in Vietnam when the population is aging, more case with the complexities like a calcified, left main, PCI, everything is become like the young cardiologists think that is a routine to do a very complex case, but actually it's not really true. So when we classify into the few things, we might consider like the population can benefit from the hemodynamic support. It is based on the patient comorbidities, the complex of the coronary artery disease, and also a lot of case we have hemodynamics compromise. So initially, people always think about the hemodynamic support just in the case with the hemodynamic compromise, like the cardiogenic shock. But it's not only true, because for about 30 to 40% of the case, when you have a very complex lesion during the procedure, the hemodynamic compromise. So that's why at this moment, you need to think about the hemodynamic support from the very beginning for this kind of things, and we can consider like usually we don't think about the mechanical support in Vietnam because very costly, but actually this group of patients is really benefit from that. So what is the main goals for the mechanical circulation support? I think the main thing is to optimize the coronary perfusion by maintaining the reasonable mean BP, and also to reduce oxygen consumption. And at this moment, we can do the complex revascularization in one step, and also to facilitate the rest of the LV function for the LV model. So basically here, this is a device in nowadays in the practice, you have IABP, Ampela, tandem heart, or ECMO. Usually in Vietnam, we have IABP and ECMO only in very expensive private hospital. We have Ampela, but it's very rare. So basically, you can see here there is two main things to support for the hemodynamic and also to help the LV unloading, because LV unloading is also another area and important for the future, because for the future when you can unloading the LV during the procedure, you can protect the LV cell, the myocardial cells, and for the long term you can reduce the heart failure. So what is the real hemodynamic impact for medical support device? You can see here for IABP is reduced afterload, but the coronary perfusion is slightly increasing, but also not significantly for the peripheral tissue perforation, and also slightly reduced PCW. For ECMO, it actually can reduce LV stroke, reduce LV preload, and even it can improve the peripheral tissue perforation. For Ampela, the afterload is neutral, but not have enough data about the coronary perforation. But for LV preload is significantly reduced. So basically here you can see based on that one, for the afterload, only the tandem heart and Impella got some significant impact. So how about the data for hemodynamic support device for cheap PCI? So it is something like a selected evidence for tandem heart for high risk PCI. You can see here for this is the feature of the high risk. The number of case is not very much because it is a rare evidence. But however, the procedure success is sky high. And you can see here, it can got quite complication due to the large hematoma, limb ischemia. We didn't see very much different in terms of MACE. Another thing is clinical evidence for ECMO for high risk PCI. So you can see here for high risk, the number of the patient is also very low. Patient, you can see here sometimes like a not procedure or no different in terms of procedure and cardiac mortality, and non-cardiac related mortalities in few cases. Another data involved in the Ampela, so we have a series of the PROTECT data showing that you can have some clinical effect to reduce the MACE for quite a few patients. And also another things involved in the observation study, also the same thing, support for the using the Ampela for high risk PCI. So when you look into the guideline, you can see here this is a guideline from 2015 from the SKY, from consensus for mechanical circulation support. You can see here this one we can consider like for proactive use for high risk PCI, especially in patients with the severe LV dysfunction like AF less than 20 or 30%, or in very complex coronary artery involving in the last territories, for example, like left main or three vessel disease. And you look for the newer things from 2021 Joint consensus from the European Association of PCI. You can see here is some indication for the device support in high risk PCI, and IABP is not should not be used for the tandem heart or Ampela should be considered in high selected patient, and ECMO should not be used. If the patient got a QMI without the cardiogenic shock, IABP is not suggested. Tandem heart and Ampela is okay. Ampela seems to be feasible as a preventive unload strategy. Even there is not much data showing that. And if the patient got a cardiogenic shock, and then the role of the ECMO increase. So through all the guideline, you can see the role of the IBP is not really evident. But this is something like in Vietnam, there is only one device we have. For the ECMO is only good for the patient with a real cardiogenic shock. Impella as or the tandem heart is very rare in Vietnam. So this is the real situation. So if you look back into the subgroup of the patient with the left main, we need the PCI. So this is a subgroup with the left main PCI. We might need, for example, like a CV LV dysfunction. A patient already have occluded RCA with the aortic stenosis with the cardiogenic shock, severe arrhythmia, or when you need the multiple dilatation because of severe calcification lesion, or the patient have acute left main occlusion when it's TAVI. And then this group, you might think about putting a tender heart, ECMO, or anything you have when you perform the left main PCI. So what is why there is a difference between the indication? Because there is a difference between the hemodynamic support and also the myocardial protection from the device. For example, like for inotope, you can have some support, but also in increasing the use of oxygen consumption, and that's why the myocardial protection is reduced. For tandem heart, support is okay, myoprotection is less. For Impella, you have both hemodynamic and also protection by the device. So that's why you see the role of the Impella is quite high in the indication, but not for really for the ECMO, because for ECMO, you might increase the afterload and then the myocardial protection is reduced. So you can see here the benefit of the device depend a lot for the LV function. For IBP, if the patient have a lot of dysfunction and then IBP is may not good, and at this moment you need to switch into another device like Impella. So the question back into how to choose the device. So based on what kind of support you need, for example, like you have a circulation support, you need to LV unloading, or you need to have a coronary perfusion. For coronary perfusion, IBP is good. Circulation support might be good, especially when the patient have a regular arrhythmia. For unloading LV is not very clear. So actually, the IBP is it can be okay for a case with the suited for the short case when you do the, for example, like a left main intervention, and you need the only temporary and short support to increasing the coronary perfusion. And at this point, IBP is really good. For ECMO, you think that ECMO is good, but actually ECMO increase the LV pressure and then the unload LV is not good. And for the long terms, the patient might have more heart failure after that. For coronary perfusion, ECMO is not. So that's why ECMO is only reserved for the case with a really complication with cardiogenic shock and pulmonary edema. In Impella or tandem heart is okay. So another thing is you can combine two things together. For example, like IABP, you reserve for the patient with the preserved LV function. Also for the patient, you might use aortic stenosis or mitral regurgitation. ECMO for profound hypoxemia, and tandem heart or Impella, you can apply for the cardiogenic shock or high PCI with the very low AEF. And sometimes you can think about how to combine things together, because when you combine things together, you can use the benefit of some device. For example, like IBP plus Impella, Impella plus ECMO, or you can use few things to reduce the side effect of the device. For example, this is how you can reduce the side effect of the ECMO by combine the few devices together. So this is very costly, but actually can save you, especially when the patient go into the very late state of the cardiogenic shock. So here is something like a summarized advantage and disadvantage of the mechanical cardio support for the PCI. You can see here the IBP is very available, easy to insert. but sometimes it requires native CO. So that's a cardio output. So that's why if the LV function is very low, then IBP is not good. And also you can have some aortic damage if the patient already have aortic disease before. Abella can be used for extended duration and not universal available, especially in Vietnam. It's too costly, and it is a contraindication if you have LV thrombus. For example, like a patient came in the very late state of the QMI, you can have that, and also need a very large broad artery access. So it might cause ischemic later on. And also there is a risk of the hemolysis and the risk of the vascular and complication risk. For ECMO, it can be used a little bit longer, but also very costly. And it might got a problem with the poor perfusion for coronary and also the celebration. So that's why you need to think about that one. For tandem heart is okay, but it's not available in Vietnam actually, and the risk similar to the umbrella. Another thing is also need to think about the potential complication, because not only for the implementation phase, but after that for the first day, first 2 days, and then the first week. So you have a lot of things like infection-related complication, acute kidney injury, accentuated complication, and also the circulatory complication like a thrombus, LV distension, especially when you use ECMO. So you need to think all the thing, and at that point you might withdraw the thing to apply the mechanical cardiac circulation support for the chip PCI. And also, please do not forget the contraindication and complication for that. For example, like IBP, if you have a very severe PDA, aortic disease, moderate to severe AR, not AS, and then there is a contraindication. If you have a thrombus in the LV, Ampella is contraindication. For ECMO, if you have something like a contraindicator for anticoagulation, then you cannot use. And if you have a very severe PID, ECMO got a lot of problem with the limb ischemia later on. So this is also think about the complication later on for all the device, the bleeding, the hemolysis, and also the vascular complication. And you can see here, actually, if we have, if you want to have a very short support for short-term device, don't have a much bleeding and vascular complication, then IBP is the tool of choice. Even the data is not very clear. So back into the practicals, how do you when you need the protection for the chips? So we have some score to identify the clinical criteria for patient need to protect. For example, like the lesion, unprotected left main, this the left main bifurcation stenosis, especially for ISR, multivessel disease with a very high syntax, lateral main coronary conducts, heavily conceived lesion because you need to multiple dilatation or CTO. And the next thing is the heart failure. If patient have a severe decompensate heart failure like EF less than 30%, and also the ventricular tachycardia, and then you need to have a support. Another thing you need to consider, like a patient have a hemodynamic parameter like a cardiac low cardiac index, high pulmonary capillary wedge pressure, or PAP, and then you need to think about the protected. And also for the patient with the comorbidity with the high STS score, for example, like age more than 37, COPD, chronic kidney disease, and especially for the patient with the PAD. Another thing is you think about the procedure criteria involved. For example, like a patient with the PDA, and then you might think about the IBP. And if the PAD is not very severe, and then we can think about the ECMO. And then we can combine everything into the one score. You can see here, if the patient got some clinical feature, or the heart failure, or hemodynamic factor, and then you can end up with add on one more point for that one. And if the patient only from 0 to 2, no need to have a protected PCI. If we have a patient got a like a number like a total score like a 3, and then you need to consider protect. And if the patient more than 4, so this is strongly considered the protected PCI. So this is the algorithm for you to identify which kind of patient should have mechanical cardiac support for the high-risk patient. And you can see here, based on the hemodynamic presentation, factor involved in the procedure, and then you can combine into the one score and to consider which one can benefit from the mechanical circulation support. And this one is after that, based on the peripheral artery disease, you can choose the device to protect that. For example, like if you have iliac femoral tortuosity, you can consider like iliac the device or IABP. Any patient got a very severe aortic stenosis, and then you can consider like ECMO. So this is something like based on the procedure related factor to choose the device. So far, there is a lot of gap in knowledge and the future, and especially like I just list a few things here involved in the we don't have enough data, especially the trial, to identify the evidence for that. For example, like the IBP, we have a very controversy data involved in the IBP, and actually IBP is very good if you can put IBP in early phase for short term for the very complex PCI, and with the LV is reserved or in the gray zone. But we don't have enough data support for that. So in the reality, when you have only one device in the cath lab, you want to protect the patient, IBP, I think is still a good choice for the Vietnamese setting. So into my conclusion for that one, I think the complex and high-risk PCI become more and more relevant. And when the mechanical circulation support, it might benefit for the patient. In Vietnam, we think about cost, but if we think about the survival for patient and also for the long-term future, you might think you need to support in the early phase. Each device have their own benefit, and then we should customize their use based on the complexity of the lesion, LV function, and also the resource limitation. Sometime in the future, we can combine the few devices together. I think it's really good, especially in the patient with the cardiogenic shock, but it's really a problem of cost in Vietnam. And so far, we don't have enough evidence to, like suggest routinely using the device in every case or every step. But that's why we need to wait for a while. And thank you very much. And we hope to see you again in our Vietnam National Congress of Cardiologists. We both have online, offline format at October from the 7 to 9. Thank you very much.
Thank you very much for the excellent presentation, Professor Quang. So I would like to ask Professor Thật Nguyen give the comment on this presentation, because you are the combine between the U.S. and Vietnam, because we know the MCS is very available in the US, but Vietnam is not available, for example, in parallel. And IBB is still the one available in a lot of cath lab in Vietnam. So what are your recommendation? What are your recommendations for Vietnamese interventionists applying this kind of mechanical cardiac support for the high risk PCI that we call the CHIP? Thank you very much, Professor Thật.
Thank you very much. I saw many cases done in Vietnam, all need in parallel. And they did, and your team did not use in parallel. So to say that, do you need it? I don't know. The reason, because I saw your team did many hospitals in Vietnam or in China did left main stenting, complex left main, without impeller. And in the US, I saw that I mentioned before the reason why we did impeller because the reimbursement is much higher. The reimbursement for a simple angioplasty case is $20,000. For impeller, it's $100,000. You see?
Yeah.
So the hospital is very happy to see us doing impeller. And when we do impeller, we have approval, prior approval of the insurance company. We don't do impeller if the case is not reimbursed. I'm sorry, I have to tell the truth. You see? So to say that, and I have one case not long ago, patient came in with acute MI. So the patient have RCA. So I suspect the patient have right ventricular hyperinfarction. So because of low blood pressure, so the patient had impeller. But the ejection fraction is 60%. I don't understand how the doctor put an impeller on a patient with EF 60%. Then in the evening, he put a right impeller because the patient had pulmonary hypertension, PAS 60. So he put a right impeller. And the next day, the patient died. And I asked why the patient died. The patient died because of a rupture of the septum, acute ASD, acute septum defect, rupture. You see. So I say that I believe that it is. I have to look at the case again. It could be because of the impeller. It causes too much high pressure. So it's not all the time easy to do. And again, why I still at my age I still do the PCI, because if we don't do it, we don't have question to do the research. You see, and you have to do it to have the answer in your research, and then you accumulate data, some similar cases, and then you write it, then you publish it. So to say at this moment, to say that how about impeller in Vietnam? I don't know, because the Chinese, the Korean, the Vietnamese, the Malaysian, they did left main disease. Japanese did left main angioplasty and stenting since 1995 without the impeller, without the MCS, and some still use a balloon pump. You see. So to say that, do I have any wise opinion to give? I said no. Okay. Thank you very much.
Yeah, thank you very much, Professor Tat. And Professor Dung, do you have any comment on this?
Professor, please unmute.
Okay, I agree with Professor Thanh Nguyễn opinion. You know very clearly about the Vietnam situation. Professor Nguyễn Tân, are you there?
Yes, I'm here.
Professor Nguyễn Văn Tân.
Yeah, teacher, I'm here. Yes.
Yeah, I know you have some K, 5-10K with our hospital cardiac arrest, primary PCI for STEMI. And when you do the STEMI in this situation, some guy needs the mechanical circulatory support. So how about your opinion about balloon pump?
Yes. Just a moment. In our hospital, we have not much case balloon pump. So some difficult case, especially in the cardiac shock, sometimes we use balloon pump. Some case we use the VAS mode. Some case, but the final result, some case still alive, so some cat die. So actually in the Vietnam, we have a little data talking about mechanical cardiac support for cardiac shock. So I think in the future we should have a study and follow up the patient after we insert the balloon pump for that patient. Yes, thank you.
Okay, and I think the Vietnam Heart Association and Vietnam Society of Interventional Cardiology, we are going to issue the consensus about cardiogenic shock. Professor Nguyễn Ngọc Quang and your team to prepare to write that. And I don't know about the treatment and management of cardiogenic shock in Vietnam. How we recommendation about the MCS, but it look like you present in your presentation. Balloon pump is very beneficial in the short term, in early stage for the cardiogenic shock. I think it's very good recommendation. How about your opinion when you prepare the consensus cardiogenic shock and management, Professor Nguyễn Ngọc Quang?
Thank you very much for your question. It is really tough for us to prepare the consensus for that, and Professor Hùng actually is a person who take responsibility for that. If we're talking about that evidence, then we stuck because we don't have enough evidence to give a very strong support. So that's why maybe the consensus will based on a lot of the expert opinion. I think that based on the new classification of cardiogenic shock from the sky, we might think about putting the support in early phase before the patient is really become a cardiogenic shock, and then we can save the life and also to save cost. IBP might be very good in very early phase, because if the LV dysfunction is very severe, then the IBP is not very useful. So if we recommend too much, and then people can think that it may not useful, but actually if we put early, then we can save about 3 or from 10 to 15% the patient can become a late cardiogenic shock. So I think that, in my own opinion, for the patient young, on the risk to become a cardiogenic shock, and then we should do something for them, and IBP is a good choice because you don't have anything else. If you put late, it doesn't work. So just do in early phase or don't do it. So it is our recommendation for IBP for that, especially when the patient to do the high risk PCI. If the patient came in with the QMI or in cardiogenic shock, and then IBP is not much useful. Thank you for that.
Okay, thank you so much for your answer. I agree with that. And I think in the September we have a meeting to approve the consensus of Vietnam Society of Interventional Cardiology for the Vietnam Heart Association, and we will discuss about that. Thank you so much, Professor Nguyễn Ngọc Quang. And by now the time later, so we would like to invite the last speaker for last presentation, last but not the least, the role of the IVI in complex PCI. Professor Nguyễn Tông.
Thank you, teacher. Thank you, everyone. So everybody can see my picture, my presentation here clearly.
Yes.
So
yeah, we can see very clear.
Yeah, thank you so much. So I want to talk role of the IVIs in the complex PCI. Today we have a lot of exciting lecturer talking about complete BCI. So the first I want to talk about complete BCI. We're talking about bifurcation with 2 stand and over 3 stand and totally length over city. Especially in the QMI, we have a lots of clause. We have standing for the bypass BCI or left main DC or which heavy calcify which float up later. So now the SKY expert consensus opinion regarding BCI risk justification difficult first in the cardiac unit shock or arrest. And the second, we have a complete comorbidity or the complete BCI. So now we talk complete BCI with the stand wraps, unprotected left main disease bifurcation with the severe cypheral lesion and the severe calcification, the CTO. So now when we choose the basin for BCI, so the first we should access this is complete BCI, which is based on the anatomy, comorbidity, and we have equipment for BCI. Especially we have a tracheotomy, a cover stand on the IVI, so especially intravascular imaging. So you know, in the Vietnam and anywhere in the world, I don't know. And also imaging guidance, IVOS or OCT. So both IVOS and OCT can give additional information over angiography and can be co-registered for the test of the BCI. And the comparison of the imaging study between IVOS and the OCT, some characteristics in the IVOS or the OCT better than one. For example, in the OCT, you can find out the TCFAs or thrombus or dissection better than in IVOS. So we have calcified, and sometimes we use IVOS for better than IVOS and the OCT. In the first, we can think it's a similarity, but however, some characteristics are different, especially pre-BCI or both BCI and the follow-up. We want to find out the neo-ischemic is hyperplasia, tension fracture. Maybe it's the OCT is better than IVOS. And up to now, the IVOS and all OCT should be considered to the detect and related mechanical problem leading to reticulosis. And the guidelines is the 2018 of IVOS and OCT, but OCT now has been upgraded to the class 2A evidence for stenting. We compare another imaging, especially CT or angiography symbol, but the imaging IVOS or OCT better than coronary angiography only. So, however, when we use the OCT, so we have MLD marks in the new standardized step-by-step OCT workflow to guide the treatment decision pre and post BCI. So now the M morphology, length, diameter. After stenting, we focus on the medical dissection, position, and expansion. Look at here the picture. You can see dissection, dissection around here, and position and the cancer nodal. Sometimes very difficult. We look at in the IVOS, but in OCT you can find clearly. Especially the picture, calcium is a problem in the complete BCI. Sometimes the calcium very difficult for stenting. So we have the plan to the stenting if the patient have a loss of calcium. And the OCT classification of the calcium very clearly. So the superficial calcium or the deep calcium or the nodular calcium, eccentric or concentric. So we have a OCT calcium score rules of 5S. When we compare with IVOS, in OCT we base on calcium score, maximum calcium angle, maximum calcium thickness, and the calcium length. So we can guess there's a setfulness, and we have a plan to repair the lesion. The lesion at risk the stand under suspension have a calcium score of 4. How to diagnose and treat calcified lesion with OCT? So we have OCT. We have a calcium here. So depend on the calcium, the deep calcium, superficial calcium, and nodular calcium. We use AC or scoring balloons or IVL or protablator for the bunking the calcium. So after that, we stent in very easy. However, up to now, we have a summary trial support use IVOS in the complete VCI. We have lots of study and the finding of the other studies. IVOS associated with lower risk of death and higher TBI TOA. Final, you can see the result of the study. We stent VCI stent based on IVOS, which will improve the MACE or the outcome of the patient. One study recently published in VSIC. Although we need the IVOS for stenting, but in real world VCI in the USA, the patient have IVOS use very low. So we look at the picture here, around 14%, and especially in bifurcation or left main, around for 30%, but another complete PCI very little. The first case I want to share here is male, 62 years old, present with a stable angina. So the patient have a stenting already for years ago. So look at the picture, which have the moderate or severe lesion in the mid LAD to proximal LAD. So now we use an OCT from the LAD to the left main. The picture show in the OCT show a very severe lesion is then from the mid to the proximal LAD. And based on the result of the OCTs, we will use a cutting balloon or something NC balloon to repair the lesion for the patient after we stenting, and after measure the diameter, and we confirm the calcium in the deep of the vessel, and then we use MLD in the clinical, so calcified mid LAD lesion, and we measure the length of the lesion and repair by the balloon first, and then we stent in for the lesion. After stenting, we use the OCT to check. Look at the picture in angiography goods and the OCT, the stent position is very nice. So we stop the procedure. So the second case, we in the 65 years old male, we present this with non-STEMI refractors, hypertension, DLB, CKD, diabetes, and the patient have the high risk for bleeding, medical treatment by DAP and statin. And the picture here, look at the RCA with the CTO in the mid, and the right side, the very severe lesion in the little left main, and we also look at the OCT, very heavy calcified from the mid LAD to the left main. Look at the picture here, and this is a picture. Some segment in the proximal, very heavy calcified around here, about 360 degrees. So this case we should continue to stent in, but however very difficult to stent in here. So we measure after LAD ostium very severe and heavy calcified around here, and a little left main we have the calcified lesion, large of calcified in the little left main. So in this case we repair protablator for the patient. So we use protablator with 1.7 fiber. After protablator, we look at the OCT, some heavy calcified fracture, and after that we can continue to stent in for the patient. You look at a lot of calcified fracture around proximal to the little left main. After that, we continue to the stenting with the techniques. One stent from the 445 in the left main LD and one stand in the circumflex with the P5 and 22. After that, we use the NC balloon port. This is the final. We check by OCT in the segment stenting. We have the stenting up position very nice, so no dissection, no gloss in the coronary from the mid LAD to the left main and the mid circumflex to the left main. This picture shows the diameter MSAs from the occipital LAD and the LCS and the distal left main very large. So the final look at the picture is very nice. Dimitri flow the left main to the LAD and circumflex. And the third case I want to show is a 68 years old male recent with a step on vagina. The patient have a teeth-both vessel disease with stenting more than nearly 10 years ago. So the patient have a high risk for bleeding and echo gas show EF about 40-45%. It's a picture here, really moderate to severe in the right side. So when we have, we can see in the left side is stent restenosis, very severe in the optio to the I'm sorry. I don't know why. I'm sorry.
Just say again.
Yeah. So quickly. This picture here, so very heavy severe lesion in the optio to the mid LAD with stent restenosis. So we use the IVUS in this situation. We look at the IVUS stent in the mid LAD to the optio very severe. So maybe in the little left main. So we measure the lesion in the mid LAD to the little left main, and after we stent, after that we stent in by this with AC balloon later. I'm sorry. So we go to the conclusion. So the yield of the IVA allows downgrading of the complex level, adequate lesion preparation, and help with interventional trajectory. IVUS and OCT do differ. Is possessing important advantage and limitation, and whether OCT is superior to the IVUS or vice versa in the optimized PCI outcome be unknown. On interventional analysis should become familiar with at least one of the modality based on individual preference and availability. Thank you very much for your attention.
Thank you very much for your presentation. Although we don't have we don't see the complete presentation, but I think Professor Merton already mentioned a lot of things involved in the role of the intravascular emerging for complex PCI. I think one thing is important for the reality is we have a few things like IVUS and OCT. And even the IVUS, we have a lot of the IVUS available in the market. So Professor Tan, can you suggest one practical question for our audience? Which type of device you should use for complex PCI in the daily practice?
Yes, thank you for your comment, Professor Nguyễn Ngọc Quang. Also now, if we have OCT or IVOS, we can use in the complex PCI. However, you know, in the Vietnam now, the IVOS is based by insurance, but OCT not paid by insurance is a problem, because you know OCT now we use for complete PCI this is helpful, but the price of OCT now is expensive. So I hope in the future the insurance is by OCT for our patient. So in our CAD labs, if we have OCT or IVOS, we can choose for complete BCI. In Thống Nhất Hospital, we have both, but another hospital, I don't know exactly. So if we have both, it's good for our interventionists. Depending on the case, we can choose the OCT or the IVOS. For example, if the patient have the CKD or the osteal lesion, so in this situation, we can choose the OCT to do the case. Yes. Thank you. Yeah.
Thank you very much. So what about you, Dr. Ngô Minh Hùng? Which device you prefer for the complex PCI if you have both?
Yes, thank you. Thank you very much for asking me the kind of question. Actually, in General Hospital, we also only have IVOS. We don't have OCT, so the choice is only one. But anyway, nowadays I use quite a lot of IVOS for left-man intervention or complex BCI because sometimes I cannot use the IVOS for the evaluation procedure. However, I use the IVOS right away after I do the ballooning because quite a lot of lesion we cannot pass through the IVOS catheter through the lesion. So I use the IVOS after that, right away after that. So IVOS is the only choice in my CAD lab. Anyway, if I have the I have the OCT, so I will use that in order to evaluate the TCFA for the patient, because nowadays a lot of patients come to the CAD lab with the age around under 40 years of age, and use the IVOS. Usually we cannot see the TCFA. Not easy to evaluate the TCFA in that kind of patient. So I want to have that kind of weapon in order to evaluate the very vulnerable plaque in order to do something more for the patient. That's my opinion about the OCT. And I learned the OCT more than 10 years ago in Asan Medical Center, but so far I don't have the machine in the CAD lab. Thank you so much for asking me that kind of question.
So what about you, Professor Tech? Can you have us some ideas of how, what is the trend of the intravascular imaging in US? Please unmute, Professor Tech.
It's faster if we do OCT, because we just inject only one. We do one injection and we have the picture. If we do the IVOS, we have to put in and we have to pull out. It takes longer. But I see that the IVOS help us to locate the lesion. Let's say, for example, in an angio, we don't know where the lesion. The IFR was abnormal, and we don't know why and where. Then you put the IVOS and you pull back, and you look on the angiogram and you look on the curve, and you will know where the blockage is. You see? So the IVOS, I like the IVOS, but it's more cumbersome because you have to pull in and out. If you have the left main or proximal LAD, it's easy. But if you have distal one, I remember the distal one and you know that the IVOS, the area, the segment inside with the wire inside is short. So it's difficult to go through the tortuous area. And when you pull back, if you're doing too fast, you curve the wire and you break the plaque, cause acute MI distally. So I give some information, and it's easy if proximal, but more complex when we use it, but give more information. But for the OCT, I like it, easy, you put it in, one injection, and you get it. But what happens if it is left main? What happens if it is the artery very big? You cannot inject enough to have the picture. So I want to hear Dr. Tan, because Tan, you do more than me these cases. I do it when we need it, but to say that in the US, we save time. So usually we don't do a lot. So Tan, what do you think between the two? What is my comment about the technique, how we use it? What do you think?
So now to do the OCT, some situation be careful because when we burst the contrast here intracoronary, the patient can become the VT. So be careful in some situation, especially slow flow or no reflow. We do not use the OCT. And because we should choose the patient carefully before you do the OCT, especially the patient have the history of the CKD, or because we in the OCT we use a lot of contrast for one burst. Sometimes the first time we could see clearly the anatomy of the lesion, so we should do another one. So a lot of contrast. Sometimes we forget the contrast we use. So final we total lots of contrast here. Yeah.
Yeah, thank you very much for the comment. So basically, we see there is some advantage and also disadvantage of the OCT and IVUS. And for practical, maybe the IVUS is more practical in the realities when you do the more complex lesion in the proximal part. So I would like to have the comment from Professor Hồ Tường Dũng.
Yeah, I agree with all of your opinion. I think the OCT and IVUS power-up technique is very useful and variable in for we do complex PCI. Also, some OCT and IVUS have some advantage and disadvantage. OCT have a very good role in look like Dr. Ngô Bên Hùng talked. The first, in the acute coronary syndrome, it can see very clearly a thrombus. It can see very clearly a thin cap fibroateroma, look like you talk, and many things. And and in instant stenosis, the OCT very excellent image recording, because I have a power-up technique, and I have many case of instant stenosis. Some case with I use IVUS, but not clearly. Very difficult to evaluate neo-atherosclerosis or the mechanism. But when we use the OCT, it's very clearly we can see neo-intima, neo-atherosclerosis, neo-calcified very clearly, and we can see multi-layer of the stent. But the disadvantage of the OCT, look like Professor Tang talked, is in the patient with a chronic kidney disease, because as you know, to recall the very good image, we must push the contrast strong enough. Some the intervention, some assistant can push strong enough. We must recall 2 or 3 times again. It's much the last amount of the contrast, and not good for the chronic kidney disease. And in very severe or complex PCI, severe stenosis and long diffuse lesion, to put the contrast, to evacuate the contrast, to record the good image, very difficult. So in some case, very difficult complex PCI look like my case in this morning, we cannot use IVI. And if some case cannot use, I think the IVERT is more easily, because in the very severe and long diffuse lesion, very difficult to put a contrast to evacuate blood outside the vessel. So I think if we have a poll of the technique, very excellent. But if we have only one, it's still excellent.
Yeah, thank you very much. And we do appreciate all the comment from the panelists and faculties. And I think the time is over. And now I would like to move on to the Professor Hồ Tượng Dũng and Professor Thạch Nguyễn to give the last word.
Professor Thạch Nguyễn, can you say first?
Very simple. I mentioned again before that I do cases now just for to understand and to do more research. Because when we see cases, we have questions and we have the right. If we raise the right question, we have the right answer in research. And so that's all I have. And I learned a lot of new things. And I still enjoy and admire the Vietnamese operators who did so many amazing cases. For us in the US, we all the time use impeller. So we have leisure time to go slow and to take pictures and to do cases. And we can prepare the lesion carefully before we stent. And if we want to do fast, then we just do the IVL, lithotripsy, and we expand the stent very nicely. And I think that this is, and we have better reimbursement, and we cut the time you do the case. Thank you very much. Okay, thank you so much for your very excellent comment from Professor Thạch Nguyễn. So it's a time to wrap up. I say something. The first today, our topic is the complex PCI. I think that nowadays the complex PCI are become more prevalent because elderly population increase and lots of elderly patients come to our cath lab, and to do the PCI for them, we must do complex PCI. So I think by now interventional cardiology, Vietnamese interventional cardiologists should learn to know and to learn how to first to assess the complex lesion, to predict what happen when you do complex PCI, and how to solve them if the complication or something happen. And we must learn to utilize the assistant tool device instruments such as the cutting balloon or scoring balloon, rotator, and we can do the interpretation of the image from the intravascular image. And sometimes when we do complex PCI, some unintentional situation happen. Look like my case, we should keep outcome, and we can solve them with your experience. You can ask your senior, and sometimes we can ask the surgery if in this situation, and we can do complex PCI successfully, effectively, and safely. So the role of the mechanical circulatory support cannot let in the complex PCI.
we have one presentation, very excellent from Professor Nguyễn Ngọc Quang. So today the topic look like the summarization, the many topic, many sessions before previous, and I hope we can learn from the very excellent lecture from Edward. We can learn from opinion discussion from Edward, PCI, Vietnam, and America. So on behalf co-chair Professor Thạch Nguyễn, we would like to thank you, the panelists with the very excellent presentation for the discuss, for comprehend our topic. And we would like to thank particularly the American faculty. By now it's very late in America, midnight. You still stay with us for look like every time. And we like to thank you, the faculty and the panelists from the Vietnam, with the very excellent presentation, a very excellent opinion and discussion. And to thank all the audience very late for the noon Sunday. So we would like to wish rest safe and stay in Thai, and good appetite for the Vietnamese people, and good night for Dr. Thạch Nguyễn and the US faculty. Thank you so much, and see you again till the next time.
Thank you very much, and see you all of you.
Everyone.
Thank you. Bye bye.
Bye bye, Professor
Bye.
Thạch.
Yeah,
Thank you.
Giờ trễ quá đây anh Thạch ạ.
Okay, that's good. This
Vâng,
time.
em cảm ơn anh
Thạch
Thạch.
nhớ cố gắng
care,
là cái
take care.
software sớm để anh em ứng dụng nha là Thạch ơi. Deep learning.
Okay,
Cảm ơn Thạch,
Thank you.
cảm ơn Phó Sư Quang,
Thank you. Bye bye.
Phó Sư Hùng,
Bye.
Phó Sư Tâm.
Dạ.
Dạ, chào thầy.
Chào anh
Em
Dũng.
chào anh Thạch ạ, chào anh Dũng ạ,
Thank you.
chào anh Tân,
Thank you.
anh Hùng.
Cảm ơn ban tổ chức và kíp kỹ thuật. Bye, see you again.
Dạ em chào các thầy.
Rồi, bye bye.